Good morning. Last week of class. This is it. Today is last skills day. So on Wednesday, we have a lot of stuff to cover, but it's not going to be skills-based, where everything up till now has been skills-based. Wednesday, we're going to cover continuing education, how to renew your certification, how to find a job in healthcare, because it is different than other industries, and we have to talk about that. We'll also talk about how to ace your interview, how to maximize your opportunities, those types of things. So we'll get into that on Wednesday, and you'll have quite a bit of practice time in class on Wednesday as well. Graduation takes about an hour and a half, 2 hours, somewhere in there. So you'll have about 2 hours of practice time. You do need to return your yellow books on Wednesday, so please remember that. All right, so hope you guys had a fantastic weekend. I did get the guided practice test done. Finally, finalized. You guys will be the first to see it. And Jake will be sending that out to your email today. Okay, I just sent him the file so that he can upload it and attach it and send it out. So I don't know whether he'll get to it while we're in class or immediately after. It depends on how much bandwidth it takes up on the computer. So we'll see, but you will get it today. All right, so over the weekend, you had chapters 8 and 9. 8 was on nutrition, and it's not a very long chapter, but it is a pretty heavy chapter if you're not familiar with nutrition. The biggest thing I want you to understand is we truly are what we eat. And if a patient has a specific diet order, we have to adhere to that order, because otherwise they may actually have health consequences. So for instance, one of the biggest ones that you're going to see is a low sodium diet. So if the patient is on a low sodium diet because they have congestive heart failure or high blood pressure or something like that, if they have an excessive amount of sodium in what they eat, and sodium hides in a lot of foods, things that you wouldn't think have sodium actually have sodium, like hard cheeses. They don't taste salty, So lunch meat, that type of thing. So even things that canned vegetables that don't really taste salty have a higher amounts of sodium. So what happens in the body when somebody takes in sodium, in order to kind of understand this, we're going to talk about the movie theater, right? Because when you go to the movies, you usually get a big thing of popcorn. And when you eat the popcorn, what is it? What effect do you get? What do you get when you eat popcorn? Thirsty. Right? So what goes with the popcorn? A big soda. You have to have the soda because you get thirsty from the popcorn, right? Well, that soda also has sodium in it. So it may quench the thirst at the moment, but you end up thirstier. And it's really interesting the way this works in the body. So what happens when you eat a lot of sodium and it goes into the bloodstream? It doesn't go out of the bloodstream very easily. And that can cause some problems in the body. So the body's only response to this is to push fluid from your cells, from your tissues, into the bloodstream. And what we're doing is diluting that sodium in the bloodstream. And we're doing it by taking water from the cells. So we end up with dehydration in the cells and in the tissues to be able to put more fluid in the vascular system to dilute out that sodium. Make sense? Okay. So this is why you get thirsty, because your brain says, hey, I don't have enough fluid in my tissues. So we drink more fluid. And if you drink fluid that has sodium, you're not really helping the matters much. All right. So where this becomes a problem is inside your vessels. Do you guys remember blood pressure? You guys remember that, right? The amount of water in the hose. More water means more pressure. So if we've already got high blood pressure and we eat sodium, that pushes more water into the bloodstream, increasing the pressure, and we call that blood pressure. So when somebody has high blood pressure and we give them high sodium, it's actually going to increase their blood pressure. That puts a lot of stress on the heart. Make sense? So if we're passing trays around and we have a patient who's on a low sodium diet and we accidentally give them a regular tray, maybe a BLT or something on there, and they eat it, they're probably, that's really good, good food. But in a couple of hours, we might actually have a much higher than normal blood pressure reading, which can have negative effects on the patient. So it's very important as CNAs that we understand that when a patient has a diet ordered, that means that there is some sort of effect on the body because of that diet. And if we're passing trays and we don't pay attention to this and we just give any old tray to any old person, then there may be some negative health effects of that. Okay. I will tell you that patients aren't always keen on following the diets that they are prescribed. And if the patient, pushes back, gives you a hard time, what would you do with that? Would you just go get them a different tray? Tell the nurse. Absolutely. Absolutely. All right. It's not up to us to explain why. We're not going to pull out charts and graphs and explain fluid dynamics in the body and, sodium, potassium pump regulation. That's not really our thing. Our thing is to recognize that the patient is at a high risk for noncompliance and report that to the nurse so the nurse can figure out a way to put this information in a form that the patient can understand and internalize and work with. Okay? All right, so let me get your scores for 8 and 9. Victoria? On both? Tempest? She's not. Jayland?
100 on both.
Thank you. Serena? Brigitte? Monica? Kaya? Thank you. Arjola?
199.
Thank you. Ito? Bobby?
195.
Thank you. Jyothi? Deja? Okay. All right. Any questions on what you missed? Any questions? Do you know why the question you missed was the wrong answer? Okay. All right. One class left. If you have not registered for the test, now is the time. The further away you get from the class, the less confident you'll be on the exam. So register and then use these few weeks between test registration and your test date to practice to make sure that you're ready for the skills.
So I haven't seen anything like on the testing thing, like I logged back in and everything and didn't show anything. And then it looks like it changed. Like it says, like whenever you say show status, it says like incomplete. And then below it says like processing. So I just wasn't sure like what that's.
What would you say?
Processing it.
Okay. Does yours say complete?
I mailed mine in.
Okay. All right.
My says complete, but I haven't gotten any email.
Okay. So you're going to need to call because it says incomplete. That means that they got your application, but there's something missing. Either they couldn't find your background check or your payment didn't go through or a box wasn't checked on the registration, but incomplete means that you need to call. Complete and processing, there's when you pull it back up, there's a box toward the bottom that says, I think it's application status. Look in there and see if it says, trying to think, it's been a minute since I've looked at that screen. Hold on. application status pending. You want to make sure it says pending in that box. When, what that means. So let me explain the process real quick and what all these terms mean. When you apply for the test, there's only two options that you'll see: complete or incomplete. Complete means they saw everything, they've got everything, they put it together, they're forwarding it on to the Board of Nursing. Incomplete means there's something missing, something wrong, something you need to follow up on. But then a little bit further down on the form, you'll see application status. Now, when it says pending, that means that they've bundled all of your stuff together. They went to the filing cabinet, they found your background check, they put it with your application, they processed your payment. So everything is together. They're sending that to the Board of Nursing. And you know that because it says pending. Okay. So we've sent it off. We're waiting, pending. We're waiting for that approval. When the Board of Nursing sends back to Prometric, hey, we've taken a look at this person. They're good to go. They're cleared for testing. They're approved. That box will change to approved. And then you're just waiting on your testing date.
It says there's like notes at the bottom, and it says if your application status is incomplete, you'll receive a separate email notification from Prometric identifying the details that are missing on your application and providing instructions on how to complete the process. I went through like all my spam, everything, and there wasn't like any email, so just call.
Call them. Yeah, call them. Yeah. Does that help with the understand kind of the process of registration? So you register, you want to look at your, so you should get an email when they get your application.
I tried to do it online, but remember I said I had seen it before
Yep.
and it just wouldn't let me go through. So I
Yeah.
email it.
That's fine. That's fine. But you'll get an email from them. What I don't like about paper applications, and I'm going to say this at the risk of, you're putting your information in a third party's hand to enter correctly. So you have no idea if the person that gets your application can read your handwriting. So they're entering all this information in the computer for you on your behalf. And if they make a typo in your email address, you'll never get any information. So that's the reason I don't like the paper, only because you're relying on that third person and they may not be able to read your handwriting. Not to say that you have bad penmanship. It's just, we're so used to electronic communication now that reading handwriting is becoming a lost art. We're used to seeing all communication in typed rather than script. So, and this is a very interesting dynamic that's happening in our society, is that we're actually losing skills because of electronic communication, which is kind of interesting. From an anthropological point of view, we're living in kind of unprecedented times. It'll be interesting. But when did you mail in your application?
Wednesday or Thursday.
Okay, so give it about 7 days or so because of mail time, and then they have to open it and enter it. So give it about 7 days. If you don't hear anything by Wednesday or Thursday, just contact them and ask for confirmation they've received it. Okay, just to keep follow up. And the reason that I say all of this is I have had students whose test date came and went, and they had no idea. They had no idea because there was a typo in their email address. They didn't get any confirmation. Their testing date went to spam and they didn't check it. I mean, if Prometric issues you a test date and you don't show up for that test date, no matter what the reason is, you don't show up for that test date, they do not give refunds. So this is why I say you've got to stay on top of this, because I have had that happen to students. And I mean, you experienced it twice with two different situations. So this does happen. So you really kind of have to stay on top of this and make sure that if you're not hearing back from them, that you are the squeaky wheel.
So I did it on Tuesday. It still says pending incomplete. So is that normal?
It says incomplete.
No, it says complete.
Oh, it says complete. Okay, so pending is good. Pending means they gathered everything up and sent it to the Board of Nursing. You're just waiting on the Board of Nursing to clear you now. Okay, so complete is what you want. Pending is good. And that can take 10 to 14 days.
Business days.
Yeah, they say business. It's usually a little less than that, but yeah, because it's a human event, it's not automated. So a human actually has to go through all that paperwork and make sure that you are legit and safe to work on grandma. All right. Remember that we still have care plan sets available. You have them in your book on page 25. The next game show will be not tomorrow, but a week from tomorrow. We'll have a new game show. And I'll be talking a little bit about the new fax system. And in my rationales that I provide after each question, I'll be explaining this is a follow the care plan question. This is an apply the skill question. This is a communication question. And this is how we know why it's that kind of question. But once you identify the question, the answer becomes super easy because there's rules that you have to apply. So like communication questions, for instance, to me, the easiest questions on the state exam, and you can always identify them because they give you a scenario and they ask you what's your best response, right? It's always about response. How would you respond? What's the best response? What should the CNA say? Right. So they're very easy to recognize. It's asking literally, what are you going to say to this person? So there's some rules we have to follow, right? We never treat an adult like a child. We've talked about that. We eliminate elimination words. So things like force, restrict, make, restrain, those are all not good answers. So get rid of those. And then we read the room. Now, read, we've heard that term, right? Read the room, right? That actually means something. Respect, empathy, acknowledge, and discretion. So you want to find the answer that is respectful, empathetic, acknowledges their situation, encourages discussion, and has discretion. So once you find that answer, you can eliminate 3 of them right away and figure out which is the right one. So to me, communication questions are the easiest questions on the state exam, the easiest. But they're missed a lot on the state exam if you don't have a framework to go by, because some of the answers can actually seem okay unless you have a framework to work with. Okay. So the paperwork or the guidebook that you're getting will go over that with you. But the game show, not tomorrow, but a week from tomorrow, which is after graduation, will go over some of those things. All right, CPR. So if you need to, take a screenshot of this. Remember that this QR code is on your first day handout, the blue sheet. Your first day handout has this QR code. You do not need CPR for the class. You do not need CPR for the test. You will need it to work in most settings. So Julie has lots of classes, and she'll get you hooked up with the right one, and she'll give you a discount.
Is it only on one day?
1 day. Yep. 1 day. And for CNAs, most places require CPR and first aid. So you have to have both, both certificates. And that's a 1 day class. She does CPR in the morning, first aid after lunch. So you come all day and get everything you need to work. Okay. First aid to me is probably one of the easier classes. If it's bleeding, put pressure on it. If they can't breathe, sit them up. If they're unconscious, roll them on their side. If they don't have a heartbeat, start CPR. I mean, it's just kind of telling you, because what happens is in the heat of the moment, we freeze. We don't know what to do, so we freeze. And freezing is the worst thing that we can do, because now our person isn't getting any kind of help. So they're bleeding freely, or they're choking, or they're, we're not taking care of the burn, or, they're not in recovery position, that type of thing. So it's just very short, very quick, very defined actions that you can take to improve the overall outcome of the patient, rather than standing there and going, I don't know what to do. So first aid is actually a pretty easy class to get through. Okay. All right. So we're at the point, I'm going to be talking about this quite a bit tomorrow, but it's helpful if you take this before we get to tomorrow, or I'm sorry, Wednesday, not tomorrow, before we get to Wednesday, because I'm going to be talking about different workplaces that you can work as a CNA. And it's helpful if you kind of know which one suits your specific personality, because not all workplaces are your workplaces. I'm a high energy person, doing the same thing every day, routine, monotonous, drives me nuts. I am not that kind of person. That is not the workplace for me. I will invent a problem to be able to solve it, right? Not a good thing for me. I need high energy. I need to be able to use my brain. I need to solve problems. So I need to know that about myself, because if I just apply anywhere and they hire me and it's not the right place for me, then I'm going to be miserable. I'm probably not going to do a very good job because I'm miserable. And this is a lose-lose situation all the way around. Then I'm going to start applying for other jobs and hope for something different. And now my employer's lost an employee that they took a chance on. This isn't a good strategy, right? Poke and hope is not a good strategy here. We want to make sure that we are targeted in our applications. We got to figure out where's the right place for me. Now, some of you need a very flexible work environment. You've got kids, you've got soccer games, you've got school, you got all kinds of things going on in your life. You need flexible. Well, then you need a setting that isn't going to make you do 3 12s in a row, right? That's not the place for you. Some of you are looking for opportunities for advancement. Some of you are like, nope, I'm good at CNA. This is where I want to be. That's going to play into your search process. Some of you are very comfortable with highly technical machines. The more beeping, the better. You're good. Some of you are like, machines? No. I just want personal care. I want to be on the personal side of things. Well, where on the spectrum do you fall? Because that's going to impact your work setting. If you're not okay with a lot of death, well, that's going to be influential in your workplace setting. You probably don't want to be involved in hospice then, right? If you want to spend a lot of time with your patients, well, then hospice might be a good setting. So we have to evaluate a lot of personality traits. And the problem is right now, fresh out of the gate, you don't know what personality traits you need to be aware of. You have no idea. So I created this for you. It's 19 questions. It's free. All you got to do is answer 19 questions about you, your thoughts, your feelings, your actions, your aspirations, your schedules, all of that. This is on my main website, 4YourCNA.com. You can find it under your ideal workplace. It's called the Workplace Personality Quiz. It's on the main page. If you take this, it'll take you 5 minutes to get through. If you take this before Wednesday will make a whole lot more sense to you. Okay? Make sense? When you take the quiz, it's going to give you this big, long printout, and it's going to say, okay, your ideal workplace setting is this: hospital, rehab, nursing home, ALF, mental health, pediatrics. It's got a whole bunch of them. But then it's going to explain why. It's going to talk about pay. It's going to talk about opportunities for advancement, scheduling, work environment, teamwork, all kinds of stuff. And then below it are all the others. So if you want to kind of skip around and try to figure out, well, what makes this setting different from this one? All of that information is there for you, and it's all free. Just go do it. All right, last review. This is it. This is it. There's no more review after this. How do we know? And we're going to do this super quick. How do we know what to do with each patient? Follow the care plan. While we're doing those tasks, we should be making, who do we report them to? There you go. Every skill starts with an opening. Every opening starts with a knock. We're going to greet the resident. We're going to address them by name, introduce ourselves by name and title, explain why we're there, get permission, close the curtain, wash our hands, get our supplies. And our cardinal rule here is don't touch the resident until your hands are clean. We may need gloves. We may not. We're not going to wear gloves for everything because then we stop paying attention. So how do we know if we need gloves if we're going to touch?
Body fluids, non-intact skin or personal.
Very good. You got it. Body fluids, non-intact skin or personal skin. That's right. If we do decide to wear gloves, the first thing they should touch is the patient. And then once you've touched the patient, your gloves are soiled. Be careful about what you're touching in the environment. And then remove your gloves correctly by pinching up at the cuff and then going underneath. If we need supplies, we have to have a place to put them. And that's what the barrier is all about. It gives us a clean place to put those clean supplies. We get the barrier first, put it on the table, then go get our supplies. Don't hold your supplies up against your uniform. One of the supplies you may need is a privacy blanket. We use them both for warmth and for privacy. 2 reasons, not just privacy. And we're going to use it anytime the patient's uncovered or undressed. That's right. We put it on top. Don't snap it or shake it. Pull the sheet down underneath so your patient's never exposed. At the end of the skill, if we use a privacy blanket and we have gloves on, what do we have to do? We have gloves on and we have a privacy blanket. We need to remove that privacy blanket. What do we have to do? Take the gloves off first. Very good. Linen rules. Most of these are repeats. Linens can't touch your uniform. You have to have clean hands to get your linens. Don't snap or shake them. Clean rolls.
Toward you.
Dirty rolls away. Very good. What can't touch the floor? What can't touch the floor? Shoes only. Yeah, everything. Nothing can touch the floor except shoes. That's right. Now, there is one exception to that I want to talk about real quick. And we've spent a lot of time on that, right? Nothing touches the floor. Not clean, not dirty. Only shoes touch the floor. There is an exception. If you are walking a patient and the patient gets wobbly on you, you probably aren't going to make it all the way back to the chair. So in that situation, this is an emergency, right? We don't want the patient to fall on the floor. So we're going to help lower them to the floor. So I want to make that distinction. Nothing on the floor except shoes, unless your patient's falling. Okay? Then we lower them to the floor before they fall. Because a controlled lowering causes less injury than a fall. Good? Good? Okay. All right. Anything that we take and don't use has to be discarded. All right. Where does the patient need to be in the bed? In the middle at all times. Doesn't matter if they're on their back or on their side, they have to be in the middle. So in order to turn them on their side, we're going to scoot them toward us and then roll them away. We are always rolling which way? Toward us or away from us?
Away.
Away from us. Remain behind, the patient's behind. Washing rules. Man, we have covered a lot of washing rules, and we got another one coming up today too. So washing rules, we don't add soap to, right, the basin of water. That's right, because we need water for clean water for rinsing. So we use a paper towel to turn the faucet on. We check it. What should it feel?
Warm.
Warm. Who else checks it? The patient. That's right. We're going to use the leaves method if we have wet body openings, eyes, nose, mouth, genitals, rectal area, wound, rash, sore, incision. Any body openings, we need that leaves method to prevent cross-contamination. If that water, whatever we wash, we rinse, whatever we rinse, we dry. If that water gets cold or soapy because we're taking a while, change it. Very good. Don't get our surface wet. Protect it with a barrier if you're working on the table or the floor, or a towel if you're working on the bed. If it's under their peri area, use a chucks. but protect your surface. And then if we're going to use lotion, what do we have to do before we put the lotion on? What do we do after? Wipe it off.
Just warm it up just
Yep. Let's talk about warming real quick. Let's talk about that. There's a million ways to warm lotion. When I was in nursing school a bazillion years ago, we used to throw the lotion bottle in our warm water. Just throw the bottle in the water and let it float. Well, still okay, you can do that. But the problem is it's not really effective because that water's not all that hot, right? It's just warm. And all it's going to do is touch the outside, the lotion that's up against the container. It doesn't really do much for the middle. And when we squeeze that lotion container, where are we getting the lotion from? The middle. So that lotion really isn't warm if you throw it in the water. I also don't like throwing it in the water just because I don't know what's on that bottle. Okay. So for me, it's much safer and much more effective to put the lotion in my hand and then use some friction to warm it up. Now, the one exception to that is if it's medicated lotion, right? Because medicated lotion is designed to be absorbed through the skin. That's its whole purpose, right? It is a transdermal medium. It's designed to go through the skin. So if I put medicated lotion on my hands and warm them up, I have just taken the patient's medication, which may not be all that great. Now, if we're just talking about medicated lotion, it's not really that big of a deal. But if we're talking about things like, I don't know, nitro cream, things that actually have medications, that could be detrimental to you. So be careful with warming up lotion. Make sure that you either have gloves on, or if you're doing it without gloves, it is a non-medicated lotion. Does that make sense? Good. Okay. Okay. Ooh, Maddie. Good morning, Miss Patty. I passed both the written and the skills. Thank you. I didn't miss a single step, and your voice was with me. LOL. May God continue to bless you. Thank you so much. Congratulations to you. We are so proud. Great job. Okay, so cleaning a basin. We clean a basin the same way we clean every other kind of basin. We rinse it, we dry it, and we store it. We want to use paper towels, though, once it's been rinsed. Just remember, you don't want to touch that basin with your dirty hands or dirty gloves. You don't want to touch the supplies with your dirty hands or dirty gloves. So don't put too much thought into this, right? Because there's always that crossover point where you're going from clean to dirty and then dirty to clean. They're not really testing us on that strongly. The test is all about rinse, dry, and store. Use paper towel to open your drawer. Those of you who go on for nursing, this is a really, really big deal. And you're going to spend probably a month learning the different techniques that you need: sterile technique, clean technique, aseptic technique, all of these different things, and practicing techniques for this. But as a CNA, we're really about personal skills. And think about yourself in your own bathroom, right? You don't, when you brush your teeth, right? You put that toothbrush away with the same hand that you just brushed your teeth with. So that toothbrush is still sitting there with those same germs, but it's okay because they're your germs. So we don't, because we're helping people with personal care skills, the whole goal is not to remove all of the patient's pathogens from their area. It's to stop introducing other pathogens into your patient area. That's the goal here. And that's why this is rinse, dry, store. Make sense? Sorry, guys, I'm really stuffy today. The allergies are killing me. All right, shoe rules. If the patient's feet hit the floor, we got to talk about their shoes. So for foot care, we have to put them on. For ambulate, they'll already be on, but we're going to acknowledge them. I see you have shoes on. or do your shoes fit well? For transferring, we're actually going to have to put the shoes on. Now, the test is going to make this as easy as possible for you. When you go to take the test and they take a look at you and they decide to pair you up with other people, then during their pair up time, right, when they kind of disappear for a few minutes, if you have transfer, they're going to try to find somebody your body size or smaller, wherever possible. So I'm looking around. I got a couple options. They're going to pick the one that has slip-on shoes. They're going to try to make this as easy as possible. So if I've got two people that I can choose from, one of them has slip-on shoes, one of them has shoes that you're going to have to tie, we're going to go with the slip-on shoe people. Okay.
You can wear those?
Not Crocs, but there's all kinds of shoes now that you can just kind of put your foot into, like the Skechers slip-in. I probably shouldn't be saying like brand names, but you know, shoes that slides. So for the test, the only requirement for, I don't think we talked about this, the dress code for the test, you don't have to wear scrubs. You can if you want to. I prefer you wear scrubs, but you don't have to. The only dress code requirement is that you have closed-toed shoes. Closed-toed shoes. So that means you can wear flats to the test. You know, shoes you just put your feet. You can't wear sandals. Technically, you could probably wear cowboy boots because they're closed-toed. Good? Makes sense? I would prefer you wear sneakers. I'd prefer you to wear scrubs. If you don't have them, don't go out and buy them for the test. Don't do that. Don't save your money. Just wear pants, shirt. Yeah, don't wear your class shirts. Yeah. So they may have you turn them inside out. Because remember what's on the back? All of our principles. Everything on that back wall is on the back. So if you turn around, you read the back of her shirt and all of those letters. And all of those letters are exactly what's on that back wall. So if you wear your class shirts, they may have you turn them inside out. So I wouldn't wear them. But please make sure you wear them after to represent us. We appreciate that. Okay. When we're putting a gait belt on, or remember, slipper socks are not enough. We need shoes. When we're putting a gait belt on, we're going to check it. How do we check it? Four fingers. That's right. Before we lift a patient, their feet have to be flat on the floor, and we're going to count before we lift them to 3. We want to make them a partner. Once we get them standing, we're going to ask if they're dizzy before we walk them. That's important. And then check as we're walking. Where should your focus be when you're walking a patient? On the patient. That's right. When we return them back to the chair, what do they have to feel before we sit them down? The chair. Good. And then we want to use proper body mechanics. That way we keep our back in tip-top shape for our career. We have to end skill with clean hands. So that's always the last step we do. And I want you to remember that. If you don't hear anything else on testing day, please remember this, because this is one step that can fail you. So when you get all done with the test, or the skill, and you've washed your hands and you went back and read that care plan and you made your corrections, if you are not 100% sure if you touched something after you washed your hands, what should you do? Wash them again. Absolutely. Wash them again. And this is super important because remember, our whole goal as CNAs is not to keep our patient environment cootie free. It's to keep this patient's cooties from going into somebody else's environment. And that's all on us. And we do that without thinking about it because we do something, we wash our hands, and then we come back over and do something else and we cootie back up and then we take those cooties out.
That's just like charting. You got to wash your hands before and after.
Before and after. Yep. Yep. So at the end of the skill, if you can't remember anything else, if you aren't sure if you touch something, wash your hands again, because the whole goal is to keep the patient's cooties in their own environment. This is the one thing that we have control over. And if I could somehow impart this to all healthcare workers. If we could just get all healthcare workers to do this one thing, this right here, in skill with clean hands. Before you walk out that door, your hands need to be clean. If we could get that into all healthcare workers, we would cut healthcare acquired infections down to nothing.
I seen that last week. I went to New York. And there's a kid that unfortunately he got shot walking out of the store. So he got paralyzed. And
Oh
he
my
was already
gosh.
brought up in foster. He was brought up in foster till the end when I took him in, but he didn't have a good life. But anyways, I literally seen a CNA walk out of somebody's room with gloves and walk into his room. And I said something, and he said, "Ma, they always do that." Just tell me, "Ma,
Yeah.
they always do that." Do you know? I got back Monday, Tuesday. Sure enough, he had an infection. Yeah. So it happens way too much.
Way too much. Yeah, I'm on a crusade for this. I really am. And if I see you in a clinical setting, I'll remind you of this. Absolutely. If I see you violating this, I'll remind you, because it's not me that pays the price. It's not even you that pays the price. It's our patient. And remember, they're coming to us for help, and help isn't help if it doesn't help, right? It doesn't matter.
Amber alert.
Yeah. Quit stealing kids.
For real.
It's another pet peeve of mine. Yeah. It's simple. It's simple. Quit stealing kids, quit abusing kids. It's simple. Okay, I digress. All right, but there's a whole bunch of things we need to do before we wash our hands. We're going to make sure that bed is in the low position, so our environment is clean and safe. So that bed has to be in low position. Take a look around. Is there anything we need to clean up? Where am I? Oh, ask about comfort. Remember, they have to hear that word, comfort. We're also going to ask about preferences. Would you like a magazine? Do you want the head of the bed up? Do you want your TV remote? You want your phone? For the test, just keep it simple. Just say magazine, just one thing, but it addresses preferences, which is what they want to see. We're going to make sure that they have their call light. You're going to open the privacy curtain. All of those things, all of those C's, right? So clean, comfort, call light, curtain, comfortable, or I had comfortable, offer a magazine, all of those things. And then we can go wash our hands because we're done with the patient. So we're done with his cooties. Let's go wash our hands. Then we're going to chart if necessary, document, and then we're going to wash our hands again because our rule is in skill with clean hands.
I've been practicing the closing since last class, and it's not on the closing, but we have to make sure they're covered, right?
Yeah, and it is up there. I skip that a lot.
That's what I thought.
Yeah, and I'm so sorry. I should be bringing that up. So the way that
Just say it out.
no, you don't have to say it. Just take a look. And the reason that I don't really address this too much is because it's part of every skill that I do. We always make sure the patient is covered at the end of the skill before we ever get to the
At
closing.
least up to the knee,
At least up to the chest.
the chest. Okay.
Yes. Yeah. Unless the patient specifically requests, and that won't ever happen on the test.
You just think about the knobby knee.
Yes, we don't want the knobby knee showing. Yeah, absolutely. Absolutely. You know, it's funny because I've been saying that now for probably about 5-6 years, right? No knobby knees, maybe a little. I've been doing this so long, I lost track of time. But I actually ran into a former student at a local store about 2 weeks ago. And she couldn't remember my name. She goes, "It's the knobby knee lady." Well, there's worse things to be known for, right?
Yeah.
It's the knobby knee lady. So all of these little sayings that I have are going to worm their way into your brain. And you may not remember me. You may not remember the class in 5-10 years from now, but you will remember some of these sayings. And that's my legacy. That's how I get this into you so it perpetuates as we move forward. So I have a lot of wacky ways of saying things, but they're going to stick. So no knobby knees. And I should be mentioning that more often in the closing. Yes, make sure they're covered specifically. But the way that I show you on the skills, we never have a patient uncovered. They're always covered either with a privacy blanket or the sheet. We never, ever have a patient that is totally uncovered with nothing on. That should never happen during any skill. And if you look at that patient and they don't have any covers at all, you took a wrong turn somewhere. Something went wrong. Okay. We're going to use a privacy blanket if we have to move that sheet. And we might move the privacy blanket to expose a very small area of the patient. But that patient should never, ever, ever, ever look like that. Not for any skill. Ever.
So when you do a bath, you cover up like with a towel the bottom and then, switch it, or how do you?
So if we are, I got to take this off. This needs to be off. Okay. So to do a bath, we have a patient covered in bed. I've done my opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do a bath. Is that okay? Close curtain, wash hands. I got all of my supplies. They're on my barrier, on my table. I'm ready. I'm going to take this blanket and I'm going to lay it out over the patient. Should I snap it?
No.
Should I shake it? No, I'm just going to lay it over the sheet. And then we're going to pull that sheet down underneath, just down, just past the waist. Because remember, we're only washing face to waist, front and back. So I don't need to go any further than that. We're going to keep the patient as covered as we can. Now, during the test, they're going to ask you to move the blanket so they can see your cleaning technique, see what you're doing over there. And that's fine. They're asking you to, we'll pull the blanket down so they can see what we're doing. But in a clinical setting, oh no, we're not doing that. We're going to lift that blanket and clean underneath, right? I don't want to have can you imagine? Let's take her gown off for a second. Can you imagine how uncomfortable she is laying there with everything exposed? She's going to be very cold. And I am a stranger. I might be a nice stranger, but at the end of the day, I'm still a stranger. How many of you guys are comfortable bearing everything in front of a stranger? Right? So we have to kind of keep this in mind. My hair's falling out. We tend to normalize this because we see all kinds of stranger stuff all the time. So to us, it's no big deal. But it's not about us, is it? Who's it about? The patient. So you can't ever forget that. Does that make sense? Okay. Now at the end of the skill, I'm all done. She's got her clean gown on. We're good to go. At the end of the skill, I don't just take this away because she's uncovered. So at the end of the skill, I've taken my gloves off and I'm going to pull this sheet up and then remove the blanket.
And for the peri care, you would put the sheet.
So sheet goes down to the knees, blanket's on, sheet down to the knees. Then I'm going to roll the blanket up. Wow, I'm really stuffy. Sorry, guys. I'm going to pull this down to the knees. Notice how she's always covered when I do this. So I'm going to pull this down. And now I've got to get to the peri area. So to do that, I'm just going to roll the gown inside like this. Let go. I'm going to expose her, but that looks a little too exposed. That's like a little too much. So I'm going to take a towel. And I'm going to place the towel over the legs. So now I'm only exposing just the area I need to. This makes her feel a little more secure. When I'm done, I'll remove that towel. I'll unroll that gown back down. And then do whatever I need to do. We're actually going to see that again today with catheter care. Okay, good. Does that help? So that's why I don't really say covered here as much as I should, because in my world, Your patient should never be uncovered to begin with. Okay. But you're absolutely right. It is, where is it?
I know it's in the book.
Yeah, this is the old one. Jake, can you make yeah, it's not on here. Yeah, it's in the book. It's on the,
Ensure covered with sheet.
yeah. And it's on that one. This is the older one. I update these every so often. This is the older one. This is closing with blanks.
What's the slide number?
20. Thank you. We're still a work in progress, guys. All right. Any questions on those principles? That's how we build our skills. So all you really had to learn in class were 11 things. And we use these 11 things to form the foundation of every skill that we learn. Good? So it's not quite so overwhelming. Make sense? Okay. All right. My daughter got me a new cup. It's an elephant. We call them heffalumps. The very first fiction story that I ever started writing was a Noah's Ark retelling from the viewpoint of two elephants, Hugo and Rolanda. And there was a spider monkey, his name was Frank, that was absolutely hilarious. I never got finished. My mom and I were writing it together. It never got finished and never got published, but it's something that we constantly talk about redoing. We lost the file like a million years ago. So we'd have to start over from scratch. But so elephants are kind of my mom's and I are our thing. So my daughter bought that for me. I have the best kids. All right. So pulse. This is a documentation skill. You have a pretty good chance of getting this. Remember, there's 4 documentation skills. There's pulse, respirations, emptying the drainage bag, and feeding. So you will get one of those 4. So you got a pretty good chance of getting this. A pulse is the measurement of how many times a heart beats over 1 minute. For the test, the care plan is going to tell you to count for 1 full minute. Make sure you follow that care plan. Normal is between 60 and 100. A radial pulse is located at the top of the thumb side of the wrist. Use 2 fingers, not the flat part, fingertips. Put your thumb on the back side. Say start and stop so the evaluators count at the same time. This is a documentation skill. Dressing a resident with a weak arm. Guys, this was like 2.5 weeks ago. This was a long time ago. It is, yeah, 2nd class. And it seems so long ago because I've shoved so much in your brain in 2.5 weeks. And that's why we do these reviews, because these skills can get kind of lost in the more recent ones if I don't bring them to the forefront. We're going to ask what your patient wants to wear. They do get to choose their own clothing. We also are going to minimize exposure by getting the clothing first, using a privacy curtain and a privacy blanket. We really want to make sure that we're preserving that dignity. Okay. We're going to lift from below with a flat palm. We're going to support the joints as we lift. We undress the strong arm first, dress the weak arm first. Don't overextend or force movement. Adjust clothing for neatness and appearance. Remember, make sure the toe seams are along the toes. The pants are on the right way and over the hips. All the buttons or snaps line up. Make sure they look good. Put your dirty items in your hamper, and the call light goes in which hand? Stronger hand. All right, hand and nail care. This is a mini Manny. I would want this skill. This is not a hard skill at all. We're going to support the wrist at all times as we move the hand. We're going to put the hand in the basin to soak, take it out and put it on a towel to wash, put it back in the basin to rinse, take it out and put it on the towel to dry. After it's dry, we're going to take the slanted end of the orange stick and clean under each nail. What do we want to do between nails? Wipe it off. That's right. Once the nails are clean, we're going to take an emery board and file any rough edges in one direction, not back and forth rapidly, in one direction. And then we're going to put some lotion on. So lotion, we warm it up first and then wipe off the excess. This is especially important with hands. Why? Why would wiping off the lotion be especially important with hands? That's right. That's right. Anything they grab is likely to slip out of their hands. This results in burns every year. Every year. People will pick up a cup of hot coffee with lotion on their hands. It slips out and it burns them. So this is actually a pretty big checkpoint as far as safety goes. Apply your lotion last. Making an occupied bed. This is one of my favorites. It's a Houdini skill. You want to make sure the patient's in the middle of the bed at all times, but we want them to take up the smallest area possible. So we're going to scoot them toward us, turn them up on their side. And then we're going to change that bottom sheet a half at a time. So that the bottom sheet that's closest to me, I'm going to loosen up, roll away, because dirty rolls away. I'm going to put the clean sheet on, attach the corners, roll the clean sheet toward me. Clean rolls toward me.
But I'm just confused.
Okay.
Because you're okay. Oh, because what side are you on?
We remain behind. We remain behind.
Okay.
The patient's behind. So remember, all of our rules always lead us to the same place, right? So we turn the patient on their side, facing away from us. We remain behind, the patient's behind. We loosen the old sheet, roll it toward them, tuck it. Put the clean sheet on, roll it toward us, tuck it.
I see. Okay, I see what you're saying. Okay.
Good. And then we're going to put them back on their back, go to the other side, do it all again.
And we tuck the clean sheet under the dirty.
Yep. It doesn't, honestly, it doesn't matter. It just makes it easier if the clean sheet is under the dirty, because what are we taking off the bed?
The dirty.
The dirty. So we want the dirty on top so it's easier to remove. Right? And when we do it that way, it's only the undersides of the sheets that are touching each other, not the part that the patient's actually laying on. Okay, not the top side of the sheet. But to be honest with you, it really doesn't, again, don't get all caught up in this. It really doesn't matter because the dirty thing that made the sheets dirty is still in the bed. The minute you put that clean sheet on, the patient touches it. That clean sheet is no longer clean. So it doesn't matter if the pillow is still on the bed because the patient is still on the bed. Good? Makes sense? Don't get too far down that hole. Yeah, because, the patient is what made the sheets dirty, right? Without the patient in the bed, the sheets would still be clean. So it's the patient that makes the sheets dirty. What's still in the bed? The patient. So we're just trying to make the best out of a bad situation. We're not trying to get it like super sterile here. Whenever possible, change the bed when it's empty. But there are some situations that we're going to run into where that's not going to be possible. Good. Once you get that bottom sheet done, then we get the patient on their back in the middle of the bed, put the top sheet on. You can make hospital corners. You should make hospital corners, but the test isn't grading you on how pretty those hospital corners are. Just get the corners off the floor because nothing touches the floor except shoes, right? But when you tuck that sheet underneath the edge of the mattress, you tuck those corners underneath the mattress, that's going to make it super tight along their toes. So what should we do? Yeah, loosen it over the toes. Then we'll change that pillowcase. Please don't put that pillowcase under your chin. Think about who has breathed on that pillowcase and coughed and sneezed and snotted and drooled and all kinds of stuff. Don't put that here. It's way too close to your holes. Okay, so change the pillowcase without holding it up against you. The other reason for that is that your uniform is not considered clean when you start work. If you hold that pillow up against your uniform, you are contaminating it. Yeah. Good? Good. Now, the pillowcase, I didn't talk to you about this, and this isn't tested. This is not tested. But when you put a pillow on the bed, the pillowcase opening should always face away from the door. So this pillow is actually wrong. The opening, that's our door. The opening should face away from the door. Now, this is a very, very old principle from like Florence Nightingale time. And the reason for it is because of TB. TB is droplet, somewhat airborne. The particles are very, very small. They can hitch a ride. So when we have tuberculosis in a facility, if that tuberculosis is able to, on air currents, get inside the pillowcase, it's now got a warm, dark, moist environment because of drooling and sweating and stuff. So you don't want that hidden area to have exposure to air. Does that make sense? Now, this isn't a big deal. Now they're not testing us on it. However, tuberculosis is becoming a much more prevalent disease again because a lot of the medications that we had to help combat tuberculosis, help get rid of it, TB has developed defenses against, because we aren't the only ones with immune systems, by the way. Pathogens also have immune systems. So if it can overcome that medication over and over, it can build up a resistant strain to that medication. So TB is starting to creep up a little bit more, and this may be a principle that is pulled out, dusted off, and put into place again in the near future. Good. So it's just a good habit to start getting into. All right. Sideline position. If we have to turn the patient, it's best if the patient turns themselves. That's awesome. You know, ask them to scoot towards you, ask them to roll. Life is good. But if they can't roll, we have to do it. If you do some prep work here, it makes the job go so much easier. So furthest arm up, closest arm crosses. So if I'm turning the patient onto their left, it would be like this. If I'm turning the patient onto their right, furthest arm up, closest arm crosses, we'll go this way. Good. So it's not right arm, left arm. It's furthest arm and closest arm. Closest knee bent, furthest knee angled. And then just roll them up on their side. Where do they need to be after the roll? In the middle. If you roll them up on their side and you realize they're a little too close to the edge of the bed, should you leave them there? No. Pull them back towards you and start again. Do not think that evaluator missed that. I guarantee you they did not. They are looking at where that patient ends up. Okay. We're going to put a pillow behind the back in a roll to keep them on their side. We're going to put one between the legs, specifically between the knees and the ankles. We don't want those bony areas to rub. And the top leg should be slightly offset of the bottom, not directly on top. We're going to put a pillow under that top arm to get it into a neutral position, and then adjust the one under the head. So it's under the head, not the shoulder. Call light goes in that bottom hand. Never, ever, ever have a call light cord going across the patient's neck. I know. You guys can roll your eyes at me all you want, but yeah, but I'm telling you that these rules exist. So the one thing you guys don't understand about testing, and this is what just really kind of throws me into a tizzy. Here's the thing. Let me give you a history lesson real quick. Before current times, the way that CNAs were certified before 1996, I think it was, the way that CNAs were certified is you went to work for a nursing home. They hired you. No experience, no qualifications, off the street, you got hired. You go into a nursing home, they teach you right there in the nursing home on real patients. They just show you what to do. The DON, director of nurses, comes down the hallway after you've been there a couple of weeks, kind of got your feet wet, and looks in the door and watches you do a skill on a patient. And then just keeps going. A couple days later, they come in and watch you do a different skill, on another patient. Little while later, they come into the dining room and watch you feed a patient. Just kind of standing against the wall, just kind of checking everything out, but they're looking at your techniques and they're making suggestions and they're correcting you where you need to be corrected. After a while, usually about 4 to 6 months, the DON would write a letter to the state and say, this person has all of the skills necessary to be a CNA. That's how CNA testing used to be done. Now, what we're trying to do is kind of simulate that, okay? So we pick 3 random skills, we have you do them, and we watch. Make sense? But that's kind of the system that we're simulating. Now, we had to get rid of that system for a couple of reasons. Once you're certified, they have to pay you more. So that DON was not in a big hurry to certify you. And also, once you're certified, you can quit and go to work somewhere else. That DON was not in a hurry to certify you. So that became a problem. It also became kind of a personality thing. Have you ever run into somebody who was kind of on a God trip, right? And they may just not like you. And because they've got power, you're never going to get certified. So we'll just call it remediation. And we're going to have you work for a year under remediation. And you're working for peanuts. But I have the power, so that's okay. Does that make sense? So the system was not perfect. So then they said, okay, well, wait a minute. Let's have a designated person just go around to all of these nursing homes on a regular basis and check off these people. So we had an outsider, an RN that we hired. She had a circuit every 3 months. She visited the nursing homes. She checked off the new people that were ready to be certified. And this was an outsider, so there was no favoritism, right? Much more objective. Well, that didn't really meet the needs of the community. So then they said, okay, well, what if we keep the evaluators in one place and we just have the students come when they're ready? And that's how we ended up with our current situation. That's why we have testing the way that we do. So every rule that you see, every rule that I talk about, like making sure the patient's feet are on the floor or making sure the patient is sitting up when you feed them, those are rules and check marks because students didn't do those things. Every check mark is because we had a certain amount of people who didn't do that, so we had to add it as a check mark to make sure that people did. So some of these check marks are just like no-brainers. But they're really not they're no-brainers to you, but they're not no-brainers universally. And that's why we have to talk about these steps. Foot care. Just like hand care, a little lower. We don't do anything with toenails. So we support the foot as we move it. We put it in the basin to soak. We take it out and put it on a towel to wash. We put it back in to rinse, take it out and put it on the towel to dry. Don't do anything with the toenails, but we are going to look at the foot. So you're going to observe for any sorts of wounds, rashes, red areas, bunions, anything that just looks weird, funky, different, whatever, report that to the nurse. We're going to put some lotion on, no lotion between the toes. Lotion holds in moisture. We've already got warm and dark there. We don't want to have athlete's foot. We'll replace the sock, removing all the wrinkles, put the shoe back on, and clean up. You can wash in between the toes. Now, I will tell you that for the test, that won't be an issue because you're working on mainly young people. In a clinical setting, you probably aren't going to be able to get a washcloth between toes, especially in our older women. And the reason for that is most older women shoved their feet into shoes that did this And what that did is it pushed all of those toes together over 40, 50 years. And now those toes don't separate. They're permanently deformed. So you may not be able to get your washcloth all the way in between each one of those toes. Do the best that you can, but that's why we soap. Okay. Good. I saw one that was really severe. I mean, really severe. She apparently, all throughout her, she was a career woman and always wore really severe pointed shoes. And her feet, I mean, they literally looked like a little pyramid. It was just, and all I could think of is, because I can't handle like high heels at all. All I could think of is, how much pain did you endure as a working, corporate person? Like, how could you even concentrate on your job when your feet are in that much pain? That's just horrible. But the things we do for beauty and style. All right, any questions on foot care? Mouth care, we're brushing teeth. What position does the patient need to be in? Upright. Protect their clothing with a towel, wet your toothbrush, brush all surfaces, let them rinse and spit as often as they need to. At the end of the skill, the patient's face should be dry. Yeah, very good. And then clean up. Respirations. This is the act. Did we do? Yeah, we did respirations. This is the act of breathing in and out counts as one. We're going to count their breathing for as long as our care plan tells us to, which in this case is 1 full minute. Normals between 12 and 20, and the evaluators are going to count at the same time you do. This is the most common skill on the state exam. Most common skill. It's also one you can practice at home. If you've got any living, breathing thing at home, you can count respirations. You can count them on dogs. You can count them on cats. You can count them on hamsters. You can count them on people. You can count them on iguanas. Whatever you got at home, you can count respirations. So it's the most common skill on the state exam, but most people have something that they can count. Fish don't work real well with this. Okay, so try not to use a fish.
If we get that one, we get pulse, or it's just
Oh, hold on. Where was I? I missed one? Oh, okay. I missed a page. I advanced too far on the page. Okay, so I'm sorry. What was your?
if we get the respiration, we get pulse, or it's like one or the other.
One or the other. You only get one documentation skill. Then you'll get one mobility skill. So it's like a range of motion, transfer, turning a patient on their side, ambulate. And then you'll get one ADL skill. ADLs is all the stuff we do for ourselves. So brushing teeth, all the washing skills, denture care, catheter care, which we're going to learn today, making an occupied bed, dressing, all of those are ADL skills. Okay, so range of motion, we've learned one range of motion. We actually have 2 more to learn today, but they're super short skills. So we follow the care plan. Care plan tells us what body part, what exercises, and how many repetitions. The exercises, flexion, extension is up, down. Abduction, adduction is side to side, away from the body. Rotation is around. Make sure you're supporting the extremity as you move it. And a range of motion is all the way up and all the way back to your starting position. Now, if the patient can't go all the way up, so if we have flexion extension of the shoulder and we come all the way up, if the patient's grimacing, wincing, saying ow, or resisting at all, then the next one, I'm not going to go that far. I'm going to go to the point of resistance and then back to the start. But we always go back to start. Who should I tell about the ow? The nurse. Yeah. Denture care, just like mouth care with an extra step. We're going to clean the dentures at the sink. We're going to use what kind of water, hot or cold? What do we need to do to protect the dentures? What do we put in the sink? Washcloth. Very good. Brush all surfaces. Brush what they've got. Store them back in the denture cup after you've rinsed it and put clean water in there. Store it on a, paper towel coaster. Very good. And then do mouth care. Then do mouth care. Change your gloves between, please. Please. If I'm the patient, I don't want those denture gloves in my mouth. Please. Ambulate with a gait belt. This is walking a patient. Your focus needs to be on the patient. We're going to put the gait belt on the patient, around their waist, over their clothes. Again, this one makes me crazy. Who in the world on the test was putting a gait belt on under clothing? Right? Who was doing that? So it's a checkpoint, which means somebody was doing it. Actually, several somebodies were doing it. So we had to make it a checkpoint. Makes me crazy. Goes over clothing. How do we know it's snug enough? How do we check it? 4 fingers. That's right. We're going to use those same body mechanics we learned, and we're going to count to 3 and lift our patient to a standing position. Let them stabilize for a second. Give them time to acclimate. Because when we stand up, all of the blood falls out of our head. It just does. Thankfully, you guys are young. Your blood vessels actually clamp to keep the blood in your brain. But as you age, that system doesn't work all that well anymore, and the blood vessels don't clamp all that well, which means that when you stand up, the blood that's in your brain falls straight to your feet, and you get a little dizzy, you get a little wobbly, you get a little woozy. So when you stand up, you kind of have to wait a second for everything to kind of kick into gear and the blood to go back up to your head so you're not so woozy. Don't forget that older people are different than you. Okay. In healthcare, sometimes we have that mindset that, well, if I can do it, they can do it. Remember, they're different. We're going to walk slightly behind and to one side. We're going to let the patient lead at their pace, holding the gait belt underneath from behind. We'll go wherever the evaluator tells us to go. So usually they give you a destination, walk to the table and back, walk to the door and back. Make sure your environment's clear before you start walking the patient, by the way. And, but walk wherever you need to go, return them back to the chair, turn them around and make sure they can feel that chair behind them before we sit down. Remove your gait belt. Partial bed bath. This is where we left off last class. We're going to use that leaves method that we learned. Leaves method. We're going to wash face first, no soap. Remember, partial bed bath is face to waist, front and back. Face first, no soap on the face. We are going to use the leaves method. So one leaf, inner to outer corner on the eye, fold it over. Inner to outer corner on the other eye, fold it over. Face, fold it over, nose last. Just water. Just water.
I did not know that.
Yep, no soap on the face. Now, the patient may ask for soap. Your care plan may say in a clinical setting soap, but for the test, it's water only, no soap. Soap is very drying to the skin. So generally speaking, we don't recommend soap on the face. We want something that's much more pH balanced for sensitive facial skin. So a face cleanser of some sort. They're not going to make us use that on the state exam, just water. Okay. Generally speaking, the older women with really good skin, right? And you'll see them every so often. They just have beautiful skin. They did 2 things. They never use soap on their face and they never use cosmetics. And they have beautiful skin. It's amazing. It's really cool. So face first, no soap. Then we're going to dry the face. Then we're going to wash the front, rinse the front, dry the front. And they don't really care how you do that as long as the armpit is last. That makes sense. Then we're going to turn the patient over, wash the back, rinse the back, dry the back. Again, they don't really care how you do this. Just get it done. And then you'll give them a little back rub before you end. It doesn't matter when you put the gown on. If you put it on before you turn the patient over to wash her back, that's great. If you wait until after everything's done, that's great too. Nobody cares. It's not a checkpoint, but make sure they're dressed at the end. Can you imagine how this patient would feel laying there completely naked with just a sheet on? Awkward. So make sure they're dressed at the end. Good? Good. All right. Oh, we also had, those are out of order. Transfer from bed to wheelchair. We are going to make sure that that wheelchair is super close to the bed before we transfer and locked. That is our critical checkpoint here. Super close to the bed because our patient cannot take steps. Our care plan told us that. And locked so it doesn't roll away from us while we're trying to transfer. Before we do that, though, we're going to get our patient sitting on the side of the bed. We're going to get their shoes on. We're going to get the gait belt fastened appropriately, and then we can bring that wheelchair over, making sure the foot rests and the leg or foot pedals and leg rests are out of the way. Lock the wheelchair, get our patient into the wheelchair using that same body mechanics we use with Ambulate. Nothing has changed here. Get them sitting in the wheelchair, and then we'll turn them around, put their feet on those foot rests by swinging those leg rests forward, and make sure they don't face the wall at the end. Give them their call light because they have to have a way of contacting you once you leave. Feeding a patient. These are in the wrong order. Jake, 32, 33, and 34 need to be reordered, please. Thank you. So make sure your patient's sitting upright. They won't be at the beginning of the skill. Make sure you actually say, can you please sit upright? You're going to offer them a hand wipe and a clothing protector before you start. You're going to sit and have a conversation. You're going to feed slow. Don't rush them. The spoon should only be half full, and the patient's going to refuse after 4 bites. Offer a drink before and every 2 or 3 bites along the way. Once they refuse, encourage them. Are you sure you don't want just one more? Can I get you something else? If you get hungry later, let me know. And then you're going to clean their face. Remember, their face should always be clean and dry at the end. And dispose of your food items, and then wash your hands and document. This skill, we don't close the privacy curtain. It's the only skill that we don't close privacy curtain for. And then pericare. Oh, I guess this is in the right order, Jake. I was thinking partial bed bath. Yeah, this is in the right order because pericare is where we left off. Okay, we use that you can cross that out. We use that same leaves method. So top to bottom is how we wash the peri area. Never, ever, ever go back up. So we're going to use that leaves method. We're going to soap all 5 leaves. We go down the middle, fold our leaf. Down one side, fold our leaf. Down the other side, fold our leaf. Skin fold our leaf, skin fold. Whatever we wash, we rinse. Whatever we rinse, we dry. Same thing. You do want to change that chucks under the patient before you start. We're going to clean the front, turn them on their side, clean the back, and change that chucks one more time during the skill. Make sure they're in the middle of the bed at the end of the skill as well. All right. Whew. Man, I don't know if I'm getting sick or what, but this is getting bad. Okay, page 147. We're going to talk about a bedpan. The class review sheets that you guys get at the end of each class, are those helpful for you?
Yeah.
Okay. Takes all the information that we went over in the 4 hours, condenses it down to a single sheet of paper. Where that's really going to become important to you is right before testing, because it allows you to review all of this information in about 20 minutes. Just by reviewing all of those sheets. Just do a quick scan of the front and back of each one of those sheets, and it will help you right before testing. Okay, so page 147, if you look down the side there, you'll see all the principles involved in this skill. They're all spelled out for you on this side. We have some skill-specific steps to learn. Down at the bottom, though, I want to talk to you about testing information. They're going to give you somebody with your level of experience 10 minutes to help somebody on a bedpan. But if you look at that next icon, you'll see that the person you're doing this on is a live testing student, you. This is a simulation skill. You are going to remain fully clothed. You are not actually going to use a bedpan, and nobody's going to be in your private areas. But you will be put in the bed. They're going to put a patient gown on over your clothing. You will be put in the bed, and somebody will put a bedpan underneath you. Now, you're not actually going to use it. Please don't use it. So this is a simulation skill, but you can't really do this skill effectively on a mannequin. It really needs a live person to be able to position the bedpan properly. Okay, good, good. So the care plan is written with that in mind, that this is going to be a live person. But remember, you're not actually going to use it. That person will be positioned in a bed at the beginning of the skill. Documentation is not required. So page 148 has your care plan at the top of the page, has your supplies at the bottom of the page, and has step-by-step instructions in the middle. Let's take a look at the care plan. It says the resident has requested a bedpan. The resident is not wearing undergarments. So go ahead and underline that or highlight it. Not wearing undergarments. And is able to wipe self. Underline that as well. So what does this mean? Well, remember that we have to follow the care plan, right? We started day one about the care plan. That was the very first thing I taught you was the care plan, right? So to you guys, this is a no-brainer. This is like, well, of course we're going to follow the care plan. I mean, why wouldn't you follow the care plan? But you guys did not know about the care plan before you walked in here. I had to teach that to you. This is new information. The majority of programs out there do not teach about the care plan. I want you to think about that for a second. The majority of the programs out there teach how to do the skills, but they don't teach about the care plan. When you go take the test, you're probably going to get partnered up with somebody that has no idea what a care plan is. So they're going to, somebody showed them how to help somebody with a bedpan. They're just going to parrot that. That's all they're doing is parroting those motions. Well, if I'm going to help you with a bedpan, that means that your pants have to come off for you to use a bedpan. So during the test, somebody may try to pull your pants off. The evaluator has to have something to point to say, you can't do that. The care plan says they're not wearing undergarments. So those don't exist. Don't take them off. They don't exist. They're not there. Do you guys understand why this instruction exists? Now, it also says the resident is able to wipe self. Because if somebody starts to clean you up, the evaluators have to be able to say, stop. You don't need to do that. Look, the patient can do that themselves. It's not your role. We're going to give them toilet paper. Now, if you understand that, right, that this care plan is written very specifically to stop students that don't know what a care plan is. In a clinical setting, chances are you are going to have to help your patients with both of these tasks. Because to use a bedpan, if we have to remove our undergarments, that's not always easy when you're laying in bed, right? If the patient can get up, they're not going to use a bedpan. They're going to use a bedside commode, a toilet, something else. Does that make sense? Okay. So if they're in bed, if they're stuck in bed and they're wearing undergarments, you're probably going to have to give them a little bit of help. Help them however you need to get this done. You're probably also going to need to help them with cleaning. And let me explain why. This is physics, guys, physics. Toileting items are always in the bottom drawer. this is a bedpan, okay? If it looks like a toilet seat, it's where the butt goes. Butt sits here. So we've got a body, a butt, and an undercarriage hanging down in here. This is not very deep. And we got an undercarriage hanging in it. Not very deep at all. Your patient is probably not going to be able to get in there and do effective wiping. There's just not enough space. Got it? Now, some patients will be able to lift their bottom up and get in there and do their cleaning. That's great. Wonderful. Those are fantastic patients. Those are not your norms. In most settings, you're going to have to help your patient clean up afterwards. And that's okay. We can do that. We know how. We know how. We wipe away from the urethra. Good? Makes sense? But for the test, we're going to take the gift that they give us. This is all about putting the bedpan in place and taking it out. It's also about the bed. The most important step on this skill has to do with the bed, not the bedpan. I'll explain that in a minute. All right. So I'm going to need this again in a minute. All right, so these are all the principles that we already know. We know to follow the care plan. We know to do the opening. We know to wear gloves because body fluids, yes. We know to use a barrier. We know to keep the patient in the middle of the bed. We know how to clean the basin, and we know to do the closing. Nothing new here to learn, okay? Nothing new here to learn. I do want to talk to you about the barrier for a second, though, because this is a me thing. This is a me thing. This table is where your patient eats lunch. I personally don't want a toileting item on this table that I'm going to eat lunch at, even with a barrier. To me, that's pretty high on my gross meter. Make sense? So if you watch my old videos, I did not use the table for this skill. I didn't put a barrier on the table. I just left the bedpan in the drawer where it lives. It's happy there. It's at home. I left it there until I needed it. I took it out and put it under the butt. Happy. But the new videos I do, because I got a lot of pushback on that from online, a lot of comments about that. So I do use a barrier on the table for this skill, and I put all my supplies on the barrier. But I do want you to remember that you always have the option to leave the bedpan in the drawer until you're ready to use it.
But how is the, because you have to wash your hands before you touch the patient.
The paper towel.
Right. So we can touch the drawer itself with our clean hands. Remember, we can't touch the drawer after our hands are dirty. So we can touch the drawer with clean hands. So I open the drawer. I put the blanket on. So my drawer's just open and hanging out. I put the blanket on the patient. I get my chucks ready to go. I put my gloves on. I put a chucks under the patient. I grab that bedpan and put it under the butt. Okay, so for me, you'll see the video. I use the table. I put everything on the table. But for me, if you decided not to use the table and leave the bedpan in the drawer in a clinical setting, you are allowed to do that and encouraged to do that. Okay. The only reason that I had to make that change is because we got a lot of pushback because people were showing something different. So I really kind of had to bring myself in line with mainstream. All right, so let's learn our skills specific steps. You need to understand something about bedpans. They are literally a last resort. So CNAs do not get to decide how patients toilet. And in reality, nurses don't even get to decide how patients toilet. This comes from the doctor's orders. Now, nurses can influence this. I can pick up the phone and tell the doctor, hey, This patient is unsteady. I don't want him going all the way to the bathroom. I'm really concerned about a fall. I'd rather use bedside commode. Can I get an order? And doctors usually trust nurses' judgments, and they'll say, yeah, you've got an order for it. Or I can say, hey, this patient is really unsteady on their feet. Bedside commode, they have no lower body strength. I need a physical therapy consult. And in the meantime, I want to use a bedpan. And the doctor will say, yeah, we'll give you that order. So nurses and doctors work very closely together. Nurses relay information and suggestions to the doctor, and then the doctor will make the final call. But this is the flow chart they have to go through to decide on a bedpan. So ideally, in a perfect world, my patient gets up and takes care of all their own bathroom needs, and I am not involved. That's what I want. I want you to go to the bathroom when you need to go to the bathroom, do what you need to do in the bathroom, and leave me out of it. That's what I want. But that doesn't always work. Sometimes that scenario where you go take care of it by yourself, I'm not involved, that's called bathroom privileges. You'll actually see it abbreviated to BRP, bathroom privileges, means that go, do what you need to do. I don't need to be involved. Now, the CNA will probably ask, have you had a bowel movement today? We just kind of take the patient's word for it. You know, we don't need to see evidence. But bathroom privileges, it's all you. Now, if the patient can't get there by themselves or can't get back by themselves or needs a little help while they're there, that's called bathroom with assist, which means they're still going to go. They still know when they have to go. They still are going to go to the bathroom. They just need a little help somewhere along the way. Bathroom with assist. So bathroom privileges, top of the list. It's what we're looking for. Bathroom with assist will give you a little help when you need it. Now, from there on, it gets a little dicey. Okay. My choices are not good. There's no good choices beyond that. So the first question I got to ask is this patient even continent? Are they aware of when they have to go? Or do they just go, right? Remember, we have pericare for that. If they're incontinent, they get pericare every 2 hours. Our system stops right there. But, excuse me, if they're continent, now I've got a couple of choices. The first is a bedside commode. Now, that's best case scenario. If my patient can't get all the way to the bathroom, it gives us a bathroom-like experience. Portable toilet brought to the bedside, and the patient just sits on it like a toilet. They use it like a toilet with or without assist, however we need to do this. And then the CNA empties it. Okay, so, but it's a toilet-like experience. So, a better option. Now, if that's not going to work for us, if our patient cannot get out of bed, we're going to consider a catheter. We're going to consider it. We don't automatically go straight to catheters because they have a high rate of infection, which we're going to see in a minute with another skill. High rate of infection, but it is a consideration. Now, if they're not eligible for a catheter, the last option I have is a bedpan. Do you see how I had to go through all of that to get to bedpan? We didn't just jump right to bedpan. The reason for that is twofold. Number one, physiologically. Number two, psychologically. Both of those are going to play into this. So first, physiologically, bedpans are not comfortable. You have urine under pressure hitting a flat plastic surface that is only this far from your undercarriage. You have splashback. You have significant splashback. That's going to impact your patient's ability to go. Have you ever peed into a toilet and got water back? It impacts you. Okay? You're like, ew. That's going to affect our patient. That's physiological. But there's a psychological problem here that's way bigger. Do you guys remember hearing that the lessons we learn when we're super young are the ones that stick with us the longest? You guys remember that? Our memory-making factories? Okay, you learned when you were about this tall, don't pee in the bed. Don't pee in the bed. Don't pee in the bed. And certainly don't poop in the bed. You learned that when you were young. That lesson is super deep in there. Just because I put a plastic bowl under your butt doesn't mean your brain's going to let you go in bed. There is a psychological restriction here that makes it very difficult for your patient to use a bedpan. Now, if you put a bedpan under a patient, come back in 10 minutes, they haven't used it. A couple minutes later, they hit the call light. I really think I have to go. You try again. They still can't use it. You'll probably get really frustrated with them because they're messing up your entire schedule, and you'll get snippy with them. Don't do that. Don't do that. We need to remain patient and understand that this is a very, very hard skill psychologically for your patient to complete. There's a couple things we can do, though. A couple things we can do to help them out. Number one, nobody wants to go with an audience. You've got a stranger on the other side of a curtain. They have a roommate. And the only thing separating them is a curtain. Curtains don't block out sound. They don't block out smell. They don't block out much. So your patient is well aware of the fact that there is a stranger 4 feet away from them. That's a problem. So if you're able to get that roommate out of the room, take them to an activity, take them for a walk down the hall, the activity, take them somewhere if they're able to get out of bed. Give that patient the privacy they need if they're stuck in bed. That's number one. Okay. Number two, you can turn on the water. The sound of running water helps with that urinary letdown reflex. It also helps shield sound. Now, as far as smell goes, you can sometimes preemptively use some sort of an air freshener or something to help with odors, odor management, potpourri, whatever that stuff is called. Things like that. Don't spray air freshener unless the nurse tells you can, because if the patient has an open wound or a respiratory condition, we can't use sprays. So check with the nurse. Do you guys see how this is really our last resort? It's also uncomfortable. Bedpans are not comfortable. So they're uncomfortable. They're psychologically restrictive. There's a privacy issue here. Your patient is just really going to struggle. And it's probably going to take 2 or 3 times before they're able to be successful. Okay. Now, there is something else that we can do, but you have to ask the nurse. This is super important that you ask the nurse for. Remember that we have urine under pressure hitting a flat plastic surface, right? We're going to get that splashback. If we are not measuring intake and output, you guys remember intake and output that we learned, right? If we're not measuring that urine, ask the nurse. But if you take toilet paper, make great big loops of the toilet paper, 5, 6, 7 big loops of the toilet paper, lay that in the bedpan, it helps absorb that urine. We have less sloshing, but it also prevents that splashback effect. So your patients are usually much more successful if you have the bedpan lined with toilet paper. Good?
Only if there's no intake or output.
Yeah, because if we have to measure that urine, we don't want the toilet paper sopping it up. The second thing that we have to consider here is your patient's probably going to have to be on the bedpan for a few minutes because psychologically restrictive, right? It's going to take a minute. Have you ever sat on a car seat, right? The seat of a car that's leather in the summer with shorts on? What does your skin do? Sticks. It sticks because we're heating up, right? So when we have leather or plastic under bare skin for any amount of time, it's going to stick. So when we go to take this bedpan out, it's going to stick to their butt. And we're going to have to kind of pull a little bit. What's going to happen to all that stuff inside the bedpan when we're pulling on it? Yeah, it's going to spill. Absolutely. Absolutely. So the Toilet paper in the bedpan helps with that. We also want to put a chucks on the bed under the patient to help with any potential spills. But we also, again, ask the nurse, we can put cornstarch or powder on the seat part of the bedpan, helps it slide under the bottom, but more importantly, helps it slide right out without sticking. We have to ask the nurse. Again, if we have any open wounds or respiratory conditions, we cannot use powders. So this is a ask the nurse situation. But a lot of your care plans may say you can use toilet paper in and powder on. And if you see that, rejoice, because it makes the skill so much easier for the patient. Good. Last resort. If we have a patient that just cannot get it done, can't go, last resort, if you get a basin of warm water and make it warmer than normal, not hot, but warmer, and have your patient just dangle their wrists in the water, that helps with it's a very old nursing trick that we've used for years. It helps with the urinary letdown reflex. Just put their whole hand and wrist in the water and it will help them go. It just physiologically it happens. It helps. So last resort, you can try the water trick. Okay. Good. Good. Remember that bedpans are a last resort. So you will probably have a question on the state exam about your scope of practice that's written something like this. Your patient is assigned to use a bedside commode. Today, they say they don't feel like getting out of bed. How would you help this patient toilet? A, give them a bedpan. B, put them in an adult brief and just tell them to go. C, use the bedside commode as ordered. Or D, notify the nurse of the patient's request.
D.
It's a hard question, isn't it?
Yeah, is.
Hard question, right? Because our care plan is telling us to do one thing, and our patient is asking to do something else. So let's go all the way back to day one. I told you there's only 2 doors for us to go through, right? So we either follow the care plan or we notify the nurse, right? So the deeper question here is, why is the patient saying that they don't want to use a bedside commode? Why? Is it because they're weaker? Are they dizzy? Are they nauseous? There's a change there. What do we do with changes? We notify the nurse. So if you see that question on the state exam, this is exactly how your brain should process it. The patient has, I can only follow the care plan or notify the nurse. Follow the care plan is one of the options, possible option. I'm going to keep that in my back pocket for a second, but there's a change here. It's not business as usual. The patient is making a request, which means that's a change from normal. So what do I do with changes? I report it to the nurse. Do you see how now that question became very easy? Good. If there's any change in the question, what do we do? Report it to the nurse. Good. Now I'm going to change that question up a little bit. You're caring for a patient who's ordered to use a bedside commode, and you can't find the bedside commode. What is an appropriate action? A, take them to the bathroom. B, put them in an adult brief. C, use a bedpan. Or D, notify the nurse.
Notify the nurse.
That's right. Now, the reason is because we can't change the care plan. We can't take them to the bathroom. We can't put them in an adult brief. It's a dignity issue, by the way. Don't do that. We can't change the care plan in any way. So our only other option is notify the nurse. Now, if that notify the nurse option was gone and instead was find a bedside commode, that would be your right answer. Make sense? They're trying to find out. This is what these questions are all about. They're trying to find out if you are going to make an independent action. Because some of you, your brains wanted you to change that care plan. That's what the test is testing you on. You have to watch for those questions. Good? Questions?
So anytime they're using any of the toileting methods, where we like walk out the room.
Yeah, we're going to talk about that. But yeah. All right. So our care plan tells us our patient can move as directed. So that means we can ask them to lift their hips, which makes this way easier. Just have them lift their hips, put their feet flat on the bed, bend the knees, and lift the hips up like a bridge. In a clinical setting, if your patient cannot lift their hips, we scoot them toward us, roll them on their side, put the bedpan against their bottom, and have them roll over onto the bedpan. Okay. That way it's a way of getting a bedpan under a patient and getting them off of the bedpan. You have them roll off of it. The problem is that keeps them kind of close to the edge of the bed, and I don't like that. Bridge is best, but roll is an option. All right. So we're going to have our patient lift their hips because our patient or our care plan says they can. We're going to put a chucks underneath the patient. Now, remember, they're not wearing undergarments. How do I know that? Care plan. That means my hands are going under a bare bottom. Do I want to do that without gloves? No, butt juice, guys. Don't touch butt juice. Okay, if you're going to put your hands under a bare bottom, you need gloves on. So put your gloves on before you put the chucks in place. You also need gloves to handle the bedpan because it's a urinary item. Then you're going to put the bedpan underneath the patient's bottom. If it looks like a toilet seat, it's where the butt goes. We're going to take our gloves off. Now, this is the most important step of this particular skill, and it's not intuitive. It's not something you might think about on your own. So if I have a patient, this is my patient. Too much going on here. I have a patient laying in bed. I have a bedpan that's going to go underneath my patient. Okay, let's make the patient a little more realistic. I have a bedpan that's going to go underneath the middle of the patient. What does it do to their middle? Raises it up. How many of you ladies can pee uphill? So what we're asking this patient to do, we have raised their middle. They are going to have to pee uphill. And if they are successful, that pee is going to run right up their back and into their hair. That's way high on everybody's gross meter. So when you put a bedpan under somebody's middle, you have to think about physics, dynamics. So if I put a bedpan there, I need to get them into a normal elimination position for them to use that bedpan. Yep. We put the head of the bed up. Do you guys see how this is the most important step? Got it? All right. Do I want to touch that bed controller with butt juice gloves? So let's take those gloves off before we put the head of the bed up. The order of that matters. We're going to give our patient their call light and toilet paper and tell them to call us when they're done. Now, in a clinical setting, I'm not standing around and waiting. I'm going to wash my hands and leave the room, give them the privacy they need. This is probably going to take a minute or 10 or a little more. I'm going to give them the privacy they need. But in a testing setting, you have nowhere to go. There are no other patients. There are no other rooms. So in the test, you're just going to stand on the other side of the curtain and wait. Now, for the test, this isn't going to take long because they're not really going. It's a simulation skill. So pretty much as soon as you walk on the other side of that curtain, they're going to say, I'm done. And you can pick up from there. But in a clinical setting, don't stand on the other side of the curtain and wait. That's creepy. It's weird. Get out. Wash your hands. Leave. Good? Now, patient was sitting in bed, had a bed up. They had their call light. They had their toilet paper. They used the bedpan, and now they're done. They said, I'm done. We're going to come back in the room, and we're going to lower the head of the bed. So we're in this position. Now, when I go to get this bedpan out from under the patient, it's full of urine or something else. We don't want that to spill. So I'm going to tell the patient, don't lift yet. Wait until I tell you. And I'm going to take a corner of that chucks and I'm going to hold the front of that bedpan down so it stays level as the patient lifts off of it. Because when the patient, so if I have a bedpan here, right? If the patient's going to lift their hips off of this bedpan for me to pull it out, this part right here under their lower back is going to get pressed down. That bedpan does this. Your bedpan is going to spill. You've got to hold that bedpan level as they lift their hips because their lower back, in order for them to lift their hips, that lower back goes down. Make sense? Physics. Ick. So hold that bedpan level, let them lift off of it, and then pull the whole thing out. The chucks and the bedpan, all of it. Pull the whole thing out. Everybody got it? Got it? Okay. So, of course, we want gloves on for this, obviously. So, the reason that we're pulling that chucks out with the bedpan is because I can't carry an open container of urine anywhere. If my shoelaces are untied and I trip over my shoelaces, I'm going to end up with a face full of somebody else's urine. It's also a privacy issue. Nobody needs to see what's in that bedpan. It's a privacy issue. So we take the chucks and the bedpan out together. That chucks then becomes our bedpan cover. Now, that's only, so we're going to time out here for a second. That's only because my patient was able to wipe themselves. In a clinical setting, if your patient needs help with that, don't take that chucks. We need that chucks under them to keep the sheets clean. We're going to take the bedpan and use something else to cover the bedpan. Another chucks, a towel, something. Grab something to cover that bedpan. Does that make sense?
Before removing it?
Once we take it out, just cover the bedpan with something. Anything. Good? Good? Makes sense? Take it to the bathroom and we're going to dump it. Now, this is a pretend urine situation. There's nothing in the bedpan for the test. Nothing in the bedpan. We're going to take that empty bedpan over to the toilet, pretending that there is urine in it. We're going to keep it covered the whole way. When we get over to the toilet, we'll uncover it. We'll dump the pretend urine into the bedside commode or the toilet. We're going to rinse that bedpan and dump the rinse water into the bedside commode or the toilet. And then we're going to dry it. And we'll put it back away. Good? Good? So 3 things I want you to remember with this particular skill. The head of the bed is the most important step. The chucks under the patient is important to keep the sheets dry, but it will also be the cover of the bedpan for the test. Okay. And number 3, your patient can lift their hips. Our care plan told us they can. If you remember those 3 things, you'll do fine on this. Questions? Let's talk about real world setting for a second. If you go into a real world clinical setting, a lot of them have this. It's a little thing on the back of the toilet. It's standing up in front of the big pipe, but it looks like a little shower head. If you pivot that forward over the toilet bowl, it'll start spraying. It is a bedpan cleaner. That's what it does. And it doesn't work in this position. You have to pivot it forward so it's spraying down into the bowl. That way it doesn't get like the whole room accidentally wet. It has to be down in that position to be able to come on. But this allows you to clean the bedpan right over the toilet, so we're not using the sink. This is awesome, awesome, awesome. But has a big problem because we have water under pressure hitting a flat plastic surface, and that causes splashback. So if we're going to be cleaning this bedpan, we have to dress for the job. We don't want whatever's in that bedpan to get on our uniform. So we're going to put one of those isolation gowns over our uniform to keep body fluids off of the uniform. We also want to cover our face with like a mask and shield, right? Because I don't want any of those body fluids to accidentally fly in any of my body openings. So if we're going to use this, it's a great tool. Make sure you dress for the job. Gown, mask, shield. A word about odors. Masks do not remove odors. They don't filter odors. Odors get through masks. So if you're putting on a mask to help with smell, it's not going to help you a whole lot. There's something else you can do. Vicks Vapor Rub right underneath the nose will help. It cuts most smells. If you don't like Vicks, or if you can't handle menthol, I can't. My eye will look like Rudolph in like 0.3 seconds. So for me, I use Vaseline. I just go to the Dollar Tree and get one of the little things of Vaseline, and I add essential oils to it, like whatever essential oils I like. Like I like orange blossom, or sometimes lemon balm or something like that. I'll add the essential oils in until it's strong enough that it cuts many odors, and then I use that. So there are ways of helping. Now, it's not going to remove all odors, guys. It does have limitations. But if you are odor sensitive, this is a great tip for you in your clinical setting. Okay. I saw something on Facebook not too long ago. I thought this was a genius. This is a multi-million-dollar idea. They now have these little plastic rings, and I can't remember the name of them, but I'm sure if you Google it, you'll find it. But they're little plastic rings that have like two balls. It's like a most of a circle and then two little balls on it. Pop it right into the septum of your nose. Yeah, it doesn't pierce it. It just, those two little balls just kind of hold on to the septum of your nose, but it's essential oils. It takes the place of that ointment. Yeah, you just pop it in, and now you're smelling fresh as a daisy all day. So I thought that was a really, really cool invention, and I'm sure somebody in healthcare came up with it. Yeah. I can't remember.
It's like a ring, so I don't know if it's O-ring. I think it's like
scent ring, or
yeah, you could always just look up like scent rings for like medical field, and I'm sure it'd be like the first thing that pops up.
yeah.
Cool.
Really cool. Really cool. All right. So now that we're done with the bedpan, we're not done with the skill. We're done with the bedpan part. But your patient wiped themselves. How do I know they wiped themselves? Because the care plan told me they wiped themselves, which means what have their hands been in? Yeah. We've got to give them a way of cleaning their hands. They're stuck in bed, guys. If they weren't stuck in bed, we wouldn't be using a bedpan. They're stuck in bed. So let's give them a hand wipe to clean their hands. Now, I know where their hands have been. I don't want to touch that hand wipe. Ew. So I'm going to get a paper towel to collect that hand wipe as a barrier to be able to throw it away. Good? So not a hard skill. A lot of steps to it, but not a hard skill overall. These are all of our principles. Let's use them to check off all of these checkpoints. We're going to follow that care plan. We're going to do our opening. We're definitely going to need gloves for this. We're going to use a barrier on the table against my advice, but we're going to use a barrier. Keep the patient in the middle of the bed. We're going to clean the basin the way we clean everything else. And we have our skill-specific steps. Now, this skill has a lot of skill-specific steps. There's a lot of black on there. So remember, head of the bed up, chucks underneath. And that chucks is going to become your bedpan cover.
If there's a chuck underneath, do we have to change it?
So for the skill, for the test, and I'm going to be very specific with my answer here. For the test, it is a live patient, fully clothed with a gown on over their clothing, placed in the bed by the evaluator. There will not be a chucks under them. Okay, so that's not going to be an issue for the test. In a clinical setting, let's talk about barriers for a second. Unless you have a reason to have a chucks under somebody, a verifiable reason, you should not have a bed pad of any kind under a patient. And the reason for that is these bed pads are going to trap in heat. Heat causes sweating. Now we've got warm, dark, moist, right under an area with body openings. So we risk infection. So we don't use bed pads under patients unless we have a reason to use bed pads under the patient. So there shouldn't, if we have a patient with a bedpan, be a reason for a bed pad to be there unless they have a wound or something. Make sense? Good? Okay. And then we always follow up with our closing. This care plan is only for this patient, nobody else. Every patient's going to have a different care plan. And let's go ahead and take a look at our video for this. I got it, Jake.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I understand you need a bedpan. Can I help you with that?
Yes, please.
Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. After I've washed my hands, I'm going to get my supplies. I'll start with a barrier, unfolding it with the absorbent side facing up, and this is going to give me a clean place to put my clean supplies. And we're going to start with the chucks, and then I'll move over here to the patient environment. I need a set of gloves, a second set of gloves, hand wipes, and I'll need the bedpan, which will be in the bottom drawer. I'm going to open the drawer, but I'm not going to touch the bedpan until I put my gloves on. We'll go ahead and put the gloves on. I'll take the barrier and prepare it by holding it up with the absorbent side facing me, and I'm going to roll it toward me. And we're going to set that aside. I'll get the bedpan and the toilet paper out of the drawer, and we'll put those on the bedside table. Now we're ready to start the skill. Okay, Mr. Jones, I'm going to ask you in just a moment to bend your knees and put your feet flat on the bed, and you're going to lift your hips up for me so I can unroll this chucks underneath you. This is going to protect your bedding while you use the bedpan. Okay? So I'm just going to loosen this sheet up a little bit so we've got some working room. I'll take my prepared chucks, and we're going to place it on the bed where we're going to unroll it under the patient. It needs to be under the middle of the patient where the bedpan is going to go to protect the sheets from becoming soiled. Mr. Jones, can you bend your knees? And I want you to lift your hips as high as you can go. Thank you. I'll unroll that chucks all the way to the other end. Okay, you can relax. There you go. Now we're going to put the bedpan under the patient. The wider end of the bedpan goes under the patient's buttocks. So this will be toward the foot of the bed. Mr. Jones, can you lift for me? Thank you. Go ahead and come down. Make sure that that's centered appropriately. All right. And now I can remove this set of gloves. We'll throw these gloves away, and I'm going to put the head of the bed up. Mr. Jones, I'll put the head of the bed up now. That bedpan may shift a little bit. Feel free to move it as you need to, and let me know when you're comfortable. And you can relax your legs. So you comfortable? Okay. Here's your toilet paper. Here's your call light. I'm just going to step on the other side of the curtain and let me know when you're done. Okay, Mr. Jones, are you done?
I am.
Very good. Let me lower the head of the bed. There we go. And I'm going to put my gloves on. All right, Mr. Jones, in just a moment, I'm going to ask you to bend your knees and lift your hips off of the bedpan. But wait until I tell you because I need to hold that bedpan flat.
Okay.
Okay? I'm just going to move this out of the way. I'll take a corner of the chucks. Go ahead and bend your knees. Don't lift yet. I'm going to take a corner of the chucks and hold the front of that bedpan down as he lifts. Go ahead and lift. And I'll pull the whole chucks and bedpan out. Relax. And we're going to take this to the bathroom for disposal. I'll bring the bedpan over to the patient bathroom area. We'll unwrap the chucks from around the bedpan and dispose of the chucks. And then we're going to dispose of the contents of the bedpan into the bedside commode. For testing, this is a simulation skill. There will not be anything in the bedpan, but we're still going to follow through with the simulation. We'll lift up both the seat and the lid. We're going to dispose of the contents of the bedpan into the bedside commode or toilet. And then we're going to rinse the bedpan. We want to put the rinse water into the commode as well. Now I'm going to set the bedpan down into the sink, disinfect it per facility policy, and then use a paper towel to pick it up. I'll take a paper towel to dry the inside. Throw that away. Another paper towel to dry the outside. Throw that away. And then one more for the drawer. Now that I've cleaned the bedpan, I'll get the toilet paper, place it in the bedpan, open the drawer with the paper towel, and then we're going to position this bedpan in the drawer and close the drawer with the paper towels. I'll then throw these paper towels away. We're going to remove the gloves and throw those away. I'll get a paper towel. Mr. Jones, I'm going to give you a hand wipe so you can wash your hands after using the bedpan. Go ahead and take a hand wipe. And then I'll collect that hand wipe after you're done with the paper towel.
Thank you.
This keeps me from touching the hand wipe. We'll throw this away. We're going to throw the barrier away. Clean our work environment. So I'll pull the sheet up. Make sure that it looks good. And here's your call light, Mr. Jones. If you need anything at all, just press that red button and we'll be happy to come back and help you. I'm going to remove your bedside table and open your privacy curtain. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Okay, your bed is in the low position. Your environment is clean. I'm going to go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator, my skill is done.
Here comes the light.
All right, any questions on bedpan? Any questions? No? We're going to go ahead and take our break. When we get back, we have 4 more skills to go over. 2 of them are range of motion, super, super quick. We're going to get into catheter and drainage bag, and I'm going to show those 2 together. But before we do that, we'll do the last 2 range of motions before we roll into that. So easy peasy. Go ahead and take your break. We are back. Okay, so before we jump into the next skill, which is catheter care, and this is basically pericare with an extra step. So we have to learn a little bit about infection control here, but the steps you already know of how to do catheter care. You already know the steps, but we have to talk a little bit about theory. But before we get to that, we're going to back up all the way to class 2 and 3. Class 2 had range of motion shoulder, and we didn't get to that. Class 3 had range of motion elbow and wrist, and we didn't get to that either. So we're going to back up and do those two. These are very short skills. Prometric says somebody with your level of experience should be able to do these in 4 minutes or less each. So let's go to page 76 in your book. And I don't have graphics for this. I do apologize. I have no graphics for you for these skills because they're way back in those other.
Are we gonna get practice on?
Yes, I'm hoping. We're going to keep our fingers crossed. Okay. All right. So page 76 has the overview for range of motion shoulder. Page 77 has our care plan. So if you look at the top of page 77, our care plan says to provide passive range of motion to the residents. Is it left shoulder or right?
Left.
Left. That's what I thought. To the resident's left shoulder. It says provide flexion, extension, and abduction, adduction. Provide 3 repetitions of each exercise, and the resident's not able to help with the exercises. So if you remember, so we're working on the shoulder, left shoulder. And if you remember, we are going to follow the care plan exactly. Okay, so left shoulder, 2 exercises, 3 repetitions each. So flexion, extension was up, down. So we're going to do that 3 times. 1, 2, keep the elbows straight, all the way up and all the way back down. 3. Abduction, adduction was side to side. So all the way out and all the way back in. All the way out, all the way back in, all the way out, all the way back in. We're going to provide support at the joints. We'll lift from below with the flat palm. We'll move slowly and smoothly and always return to start. Make sure you're monitoring for pain. That's the skill.
Is up and down 1?
Up and down is 1. Yep. So that's it. That's the whole skill. Put an opening in front, put a closing in back. That's the whole skill. So we're going to show you that video. Then we're going to talk about elbow and wrist. It'll take me 2 minutes to show you that one. And we'll watch that video and then we'll get back on track. Okay? Good? All right. Class 2, Jake.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I need to do some range of motion exercises on your left shoulder. Is that okay?
Yes.
Let me close your privacy curtain and wash my hands. I'll be right back. Okay, Mr. Jones, the first exercise I'm going to do is bring your arm above your head and back down to the bed like you're asking a question. I'll do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay?
Okay.
So we're going to bring your arm all the way up, supporting at both joints. Slowly and smoothly, all the way back to start. Here's 1. We're going to do that 2 more times. Up, still okay?
Yes.
Back to the bed, and 1 more. Up, and back to the bed. Okay, The next exercise we're going to do is bring your arm out and back in like you're making a snow angel. Okay?
Okay.
So I'm going to support at 2 joints. We're going to go all the way up and all the way back to start. Feel okay?
Yes.
All the way up and all the way back to start. Still okay?
Yes.
One more. All the way up and all the way back to start. Good?
Yes, ma'am.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. Bed is in the low position. Let me give you your call light. Here's your call light. If you need anything at all, just press that red button. We'll be happy to help.
Thank you.
I'm going to open your curtain and go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. Okay, any questions on that one? All right, let's go on to page 78. 78 has the same overview. If you go to page 79, it shows you the care plan at the top of the page. This care plan says to perform passive range of motions to the resident's right elbow and wrist. Flexion extension, provide 3 repetitions of the exercise and the resident's not able to assist. So it tells us the body part. Which body part? Right elbow and right wrist. Tells us what exercise. Flexion extension tells us how many repetitions. 3. So elbow only moves in one direction. An elbow will only do this. Don't make it do anything else. You break it. Okay. So 1, 2, 3. Wrist can move in all different directions. It's an articulating joint, but the care plan tells us how to move it. It says flexion extension, which is up and back. 1, up and back. 2, up and back. 3, put an opening in front, put a closing behind. That's the whole skill. This is the shortest skill we do. Shortest skill we do. It's even shorter than shoulder. For CNAs, yep, for CNAs, all CNAs do without additional training is flexion extension, abduction, adduction, and rotation. That is all CNAs do without additional training. Now, you can be trained to do other exercises, but from a basic standpoint, that's what we're going to do. Okay. Yeah, chapter, yep. Yeah, chapter 9 does go into quite a few. But see it? No. No. The test isn't going to test you on those. All right, Jake, go ahead. This is going to be class 3, range of motion, elbow and wrist.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to do some exercises on your right elbow and wrist. Is that okay?
Yes.
Let me close your privacy curtain. I'm going to go wash my hands, get my supplies. I'll be right back. Okay, now that I've washed my hands, I'm going to have you extend your arm out, palm up. I'm going to do all the exercises. All you have to do is let me know if there's any pain or discomfort. I'm going to bend your wrist up towards your shoulder like you're making a muscle, and we'll do this 3 times. So all the way up and all the way back to start. Up and all the way back to start. Feel okay?
Yes.
One more. Up and all the way back to start, making sure the elbow is on the bed. Now we're going to move on to the wrist. We're going to move the hand up and down like you're revving a motorcycle, so light fist. You'll feel a little stretch. Let me know if there's any pain. We're going to go forward and back. Feel okay?
Yes.
Again, forward and back. Still good?
Yes.
One more. Forward and back. Okay?
Yes.
Very good. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Here's the call light. If you need anything at all, press that red button. We'll be happy to come help.
All right.
Your environment is clean. Bed is in low position. We'll go ahead and open the curtain and I'll go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. Questions? As I said, I wasn't too worried about missing those two because they're so short that it's easy for me to pop them in at the end. All right, so let's go back on track to page 158. We're going to talk about catheter care. Catheter care is peri-care with an extra step. So if you look down the side here, you can see all of the principles involved, which are all of them except shoe rules. So this is a really big skill. We have all of these principles. Down here, somebody with your level of experience should be able to do this in 15 minutes or less. This is going to be done on a mannequin. Mannequin will be laying in bed. Charting is not required for this particular skill. Page 159 gives us our care plan at the top of the page, our supplies at the bottom of the page, and step-by-step instructions in between. Here's your care plan. It says provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Clean the catheter tubing and perineal area only. So if you remember peri-care, okay? With peri-care, we change the chucks, we clean the peri area, we turn the patient over and clean the backside, and then we change the chucks again. This was peri-care. Everybody remember that? Catheter care is very similar, except our patient isn't going to start out with the chucks. We're going to put one there to keep the bedding dry while we clean. We're going to wash the peri area, middle, side, skin fold, exactly the way we did peri-care. We're also going to wash the tubing, moving away from the urethra using the Leaves method. And then we're going to remove that chucks from under the bed, or from the bed under the patient. Okay, so peri-care was chucks, front, back, chucks. Catheter care is chucks, front, tubing, remove the chucks. No back. And the reason for that is our care plan says to clean the peri area and tubing only. So we're going to follow the care plan. Good? Good? So let's learn these steps that we need to learn. So for peri-care, we wash the backside. For catheter care, we don't. For peri-care, we change the chucks at the end. For catheter care, we just take that chucks away. Remember I said a few minutes ago that it's not good to leave a chucks under a patient that doesn't need one? This patient doesn't need one. So let's talk about catheters, because that's really, I mean, you know all the steps of this. I could let you loose and you could do catheter care. You know the steps. What you don't know is what a catheter is, how it works, how it stays in the body. Am I going to hurt the patient? There's a lot of fear around that. So we're going to demystify this skill by learning about catheters and bags and how they work. All right. Catheters are inserted and removed by nurses. This is not a CNA task. In some states, in some settings, CNAs can be trained to remove catheters, but that is not a basic CNA skill. That would require additional training. Okay. So for you guys right now, as a base CNA, CNAs do not put them in. They don't take them out. We just keep them clean. That's it. That's what we do. So in order to understand how catheters work, to get rid of your fear, because you have a lot of fear around catheters right now. I know you do. But in order to understand how catheters work, I've got one here to show you. So this is a catheter, okay? It has a hole at the top. It's got a big hole at the bottom. It's a straw. It is no different than this straw. It is a straw. It's a flexible straw. The only difference is this one's kind of rounded at the top to make it easier to get in. That's it. But there's a hole at the top and a hole at the bottom. It's a straw. Now, if I put this straw in and let go, it's just going to fall right out. It won't stay in. So I've got to have a way of keeping it in the body when I put it in. And that's what this is. This is a balloon. Down here, I've got a port. This is a tube in a tube. I can inject some water, sterile water, and that now sits on top of that valve. Remember that valve we talked about with pericare? This just sits on top of that valve and keeps it from being pulled out. That's it. The patient can't feel this. It's inside a bladder. Bladder's hollow, open, big organ. The patient cannot feel that. It's not pressing on anything inside. Got it? Got it? Now, if I want to take this catheter out, I'm not going to pull it because, ow, right? This is going to have to go through that valve. And this is too big, valve's too small, that ain't going to work. So all I would do is take the water out using a syringe. And it deflates, and then it just slides right out. So catheters are not mystical. They're a straw with a doorstop. That's all they are. Good? But CNAs don't take them out. We don't put them in. But I do want you to have a brief idea of how they work so that you're not afraid when you're cleaning. Good? So this is exactly what I just showed you. When a catheter is put in, it's smooth. That allows it to go in. And once it's in place, that balloon is inflated with a syringe. It expands, but it's inside this big hollow organ. You can't feel it. When we want to take it out, we deflate that balloon and it just slides right out. Questions?
Has the balloon ever popped?
We're going to talk about that. Yeah, we're going to talk about that. All right, so CNAs are responsible for cleaning the catheter and the skin around it, and that's usually done once a shift. CNAs are also responsible for inspecting the bag. We don't want the bag on the floor. Remember, nothing on the floor except shoes, right? So the bag should never touch the floor. It should also never go above the level of the patient's hips, because if the catheter gets pulled up above the hips, whatever urine is in that tubing is going to go right back into the patient. And I don't know about you, but urine really should be a one-way trip. Okay. Don't want recycled urine back in the patient. All right. So make sure that the tubing isn't kinked. It's not touching the floor, nothing like that. So this is an entire system. This is actually called a closed system. We've got this end way up here inside the patient. Okay. Way up. It's inside the patient. We've got a whole catheter. That catheter attaches to tubing that leads to a bag, and the bag is closed. Closed system. No opportunity for anything to get in or anything to get out other than through this hole inside the bladder or this hole where we empty it. Those are the only two spots that are open in the system, and one of them is in the patient. As a CNA, we're going to be very concerned with this one because we're going to empty this bag a little bit later. And if we're not super careful, we're going to let bacteria into this system. But these are all the parts of the catheter system. You've got the catheter tip, which is has a drainage hole in it. You've got the balloon. You've got the catheter tubing itself. You've got the emptying port and the filling port for the balloon. You've got the catheter or the bag tubing. You've got the drainage bag itself. You've got some markings on that bag. You've got the emptying port, and then you've got its little house here. That's where it lives. So the catheter and the bag are two separate pieces on purpose because the catheter can stay in place up to 30 days. We only change a catheter out every 30 days if the patient needs to keep it long term. The more often you change that catheter out, the more likely you are to introduce bacteria into the bladder. We don't want to do that very often, so every 30 days. But the bag itself should be changed about once a week. So if we have a catheter, it's in place for 30 days, and a bag that has to be changed once a week, they have to be two separate pieces. Good? Now, CNAs can be trained to change the bag. Trained, not initial. You have to be trained. Because remember I said right now, there's only two openings. One of them is inside the patient. The other one is down here, way far away from the patient. But where we're going to change the bag is right here, way closer to the patient. So if you change this bag, you risk introducing bacteria into the system. So that's why you have to have additional training. Good? Make sense? Okay. So CNAs empty the bag. That's what we do. We also clean the catheter and the skin around the catheter. That's what we do. We do not change it unless we've been trained. Now, this is where a lot of students go wrong on the state exam. There are a significant amount of students that separate these two pieces and take this whole bag over to the bathroom to empty it. That is an opening that leads directly to the bladder. That's a problem. We don't separate these two pieces. As a CNA, we use this port to empty the bag. Good? All right. So infection control is our biggest risk here. This is called a catheter-acquired urinary tract infection, or a CAUTI. You will hear that term, CAUTI, C-A-U-T-I, catheter-acquired UTI. These are deadly. These kill patients. They kill patients. And I'm going to explain why, but you need to remember the chain of infection, okay, in order to understand this. So we got two kidneys. Those kidneys produce urine 24 hours a day. We learned this last class. This is nothing new. That urine falls down tubes called ureters, and they accumulate in the bladder. We've got this little valve down here that keeps the urine in the bladder. Well, when we have a catheter, all we're doing here, we put the catheter in place, and do you see what it's holding open? That valve. That's its whole job. That's a catheter's whole job. It is there to hold that valve open and allow the urine to go through the tube instead of through the patient. That's a catheter's whole job. That's all it does. So if it's holding that valve open, that means that no urine is accumulating in here. But your patients will often say to you, when they have a catheter, it feels like I have to pee. Well, there's no urine in the bladder. The urine just goes down the tube as it's produced. There's no urine in the bladder. What the patient is responding to is the tip of the catheter. So because the bladder is not expanding, it's staying small because it's not full, the top of that bladder is actually way closer to the top of the catheter. So the catheter hits the top of the bladder. The only thing that's ever hit the top of the bladder ever is urine. So the bladder feels something hit the top of the bladder and it says, hey, it must be pee. So it tells the brain, hey, I think we have to pee. And the brain tells you, hey, I feel like I got to pee. As a CNA, you can just tell them the catheter takes care of that automatically. Yeah, that sensation goes away. So patients usually get used to this about 10 to 12 hours. So if they can get involved in a book, watch a TV show, distract themselves somehow, this sensation of having to pee kind of goes away. They don't have to bear down. Remember, bearing down is just to open the valve. Valve's already open. Right? They don't have to do anything. It's just a sensation that will eventually go away. Now, that's different from pain. If your patient says, it hurts, believe them. Some patients end up with Charlie horses in their bladders to push this tube out. And when I say hurts, I mean hurts. Like on a scale of 1 to 10, 23. It hurts. This is a very small percentage of our population that gets this. Very small percentage. But it is an emergency when it happens. So if the patient says, I got to pee, that's normal. Patient says, it hurts, go get the nurse right away. Not after break, right away.
That happened to me. I had a partial hysterectomy,
Mm-hmm.
and it was hurting, and nobody would believe me. I was like, you know what, I'm going home. It was the next day. I'm going home. He goes, no, you're not. I said, yes, I am. Do you know he gave me that little thing to take my own out? He said, but you got to leave it in. I swear to God, you got to leave it in.
Oh
For
my
3
gosh.
days. I literally it was hurting this bad. I went to a restaurant, went in the bathroom, and undid it. And I was done.
Wow.
Yeah.
Yeah. Yeah. So have you ever had a Charlie horse of the leg?
Mhm.
You know how bad they hurt? Yeah, this is inside. This is the bladder. So it hurts. Now, the problem is it's such a small percentage of the population. It's very rare. But there is a medication we can give to people that puts the bladder to sleep. But it has some risks. It has some side effects. And in some people, again, a very small percentage of the very small percentage, right? So very small, but still a risk. When we put the bladder to sleep, it might not ever wake up again. So it is a risk. So we have to be very selective. In that case, it's better if I've got a patient with bladder spasms and I'm not really looking at I don't want to entertain that risk, then I'm probably going to have to figure out, is the catheter really necessary? And that would be the next thing to figure out. But yeah, I mean, I can train patients to take out their own catheters. That part I'm not really worried about. I'm more worried about the fact that they didn't take that seriously. And if you ever have another catheter again in the future, you're likely to react the same way. So please make sure that if you have any surgeries, you let the surgeons know that this is a potential risk.
So would this be the only emergency where we would run to the nurse? Because you know how it's like, don't run to the nurse, take action, don't leave the patient.
Yeah, in this situation, your patient is in pain but stable, right?
Okay.
There's nothing, because safety needs action, right? Safety needs action. But at this point, there's no action we can take
Right.
as a CNA. So we're just going to go get the nurse. Yeah. And hope that you don't end up with her nurses. Yeah.
On
Yeah.
the test, they're not going to show us what we exactly need, are they?
Mm-mm. No, you have to know that. That's why I keep saying flashcards, flashcards, flashcards. You have to know your supplies. Now, has anybody done the online course yet? Have you gotten into the online course? You guys were all registered for the online course on the same website you registered for class in, courses.4YourCNA.com. Just click on the top button. It says access course. Click on that. Every skill that I teach you has an activity where you have to gather your supplies. It has all of the supplies on the screen, and you have to click on the ones you need. It's a great way, especially because the flashcards are small. It's a great way for you to interactively learn those supplies. A year. A year.
It's 4-year course.
It's courses, COURSES.
Actually, you do it. You send us a thing.
Yep.
every time.
Yeah, it's in the wrap-up emails.
It's
Yeah,
there.
it's in the I actually think it's also, hold on. Yeah, it's on your welcome sheet. And the very first, in your book, the very first page, the website's right there. Yeah. So we try to make sure that you have a million ways to find our stuff. Guys, I have created so much content. And most students only, access maybe 10% of what we've created for you. If you do everything that I've created, there is no possible way you can fail. No possible way. Because, you guys are only realistically in class, you're only getting maybe 25% of what I actually created for you. You've got the book. We got that whole online course. We've got the game show. We've got your class review sheets. We've got the wrap-up emails, and there's so much content. It's no wonder I'm tired, right? And now you got the new guided thing. And please give me some feedback on that, because I've been bottled up with all of these questions and all of this content that I lose objectivity. I can't really tell, is this going to be effective or not? So I need you guys to chime in and let me know. All right. So all this catheter is doing, all this balloon is doing, is holding that catheter in place to keep it from coming out. Now, it's water filled. It's not rigid, so somebody can pull that out for sure. You pull hard enough and a catheter will come out. Patients pull them out all the time. But do you know who does it more than patients? CNAs. Absolutely. Because if the bag is on that side of the bed and I'm trying to get the patient out of bed over here, I'll pull that catheter right out of the patient as I move them out of the bed. Yeah, walking patients, moving patients, we dislodge catheters like there's no tomorrow. So it's up to us, if we're going to move the patient at all, to look to see, is there a catheter? Don't rely on your report sheet to tell you that information. Use your eyes, because that might have gotten missed, along the way. Patients do pull them out. CNAs do pull them out. We're going to talk about that in a minute, about what to do when they come out. But the goal is to not have that happen. So that's why we kind of have to go over this kind of stuff. So we have the catheter in the patient, in the bladder. The balloon is inflated. It's attached to the bag. And we don't want to open this section right here unless we've been trained to do so. But the other reason that it is 2P system is because there's different kinds of bags that we can use. And I'm going to go into that in just a few minutes, okay? There's different bags. Right now, we're just talking about a bedside bag, which is the big bag, holds a lot of urine. But there's some smaller bags that we can use if the patient needs to be more discreet. So that connection can be used to change the bag, but also to change the type of bag, okay? So why is this important? Why do we care? Well, it's because of this. It's because of the infection risk. If we let bacteria or any pathogens into this bag, so if we aren't really careful when we open this and we let pathogens in, they're in a decent environment to procreate. We don't need boy pathogens and girl pathogens to have baby pathogens. It doesn't work like that. They just need the right conditions, and they zip themselves in half, and now there's two. Boy, wouldn't childbirth be so much easier that way, right? Doesn't work like that. It does for pathogens, though. So they just divide into two. Well, urine is a good medium for that. It has the proteins and the enzymes. So if we let bacteria in here, we're going to get more bacteria than we started with, because they will procreate. And then they will start to climb. Now, they're looking for that warm, dark, moist. Right now, it's warm, but not really warm. It's not dark, but it is moist. So we got 2 out of 3. As they climb, it's getting warmer because the urine is fresher. So they really ramp up. By the time they get here, now we blocked out light. So we got warm, we got dark, we got moist. We are going. So by the time those bacteria climb into the top of the catheter and they start to jump out, we're not talking about 1 or 2 pathogens. We're talking about 1 or 2 trillion, because along the way, they multiplied and then they multiplied and then they multiplied, and it's exponential. So we can have a patient who is perfectly healthy and 30 minutes later has a raging infection, because all of these pathogens invaded that quick. It would be like all of Canada invading Florida in 15 minutes. We'd run out of place for the bodies. And that's what happens here. And this is why catheter-acquired UTIs kill patients. Because remember, we don't put catheters in healthy patients. These patients have something else going on. Their immune system currently busy. And yet we just introduced a ton of new pathogens into the system. And this is why this is likely to do them in. So catheters are very, very important when it comes to managing patient infections. Good? Make sense? Yeah, the bladder is the ideal breeding environment. Ideal. It's like going on vacation with an open bar, all you can eat buffet, fruity drinks, palm fronds, and they are just going to procreate like there's no tomorrow. We want to try to prevent that. Well, there's only 3 places that these pathogens can get into the system. This one that's inside the patient, we can't do anything about that. This one, which we should not touch. And then this one down here. Now, this is the furthest away from the patient. So it takes a long time for pathogens to climb. That's why it's relatively safe for CNAs to empty the bag. Plus, we change the bag every week. So by the time the pathogens get close to the catheter, ideally, we're taking them away. Okay? But that's why we have to have additional training to intervene here. Because if we let bacteria in here, that's way too close to the patient's bladder. Good? Good? All right. So bags have to hang on a non-moving part of the bed above the floor. They cannot touch the floor. Don't raise the bag above the level of the patient's hips because urine will flow right back into the patient, which is gross, but it's going to take all of those pathogens that are in the tubing with it. And be careful not to let this catheter tubing coil near the floor. If the catheter tubing is coiled near the floor, your leg is likely, or your foot's likely to get caught up in it. And if it's not yours, it's going to be this guy's wife or family member or the phlebotomist or the x-ray person or all the other people that come in and out of that room. And somebody's going to pull that catheter out. Okay. Sometimes patients do it, especially confused patients. It's not the end of the world, guys. It is not. You'll see a little blood because we've got a bulb this big going through a tube this big. You're going to get a little blood. The patient's not going to die. It's going to be okay. But man, that's going to sting, especially if they have to try to pee through it. Now, with every injury comes swelling. That's the real problem here. Because if a catheter gets pulled out, I have to intervene somehow as the nurse. I got to figure out what my next step is. If my patient's confused and just going to pull another one out, we're going to come up with a different solution because this one isn't working. But if I am going to put another catheter in, I've only got about 45 minutes before the swelling is so severe, I'm not going to be able to get a catheter in. Swelling. Now, that means this patient can't have a catheter for the next several hours until that swelling subsides. It also means that it may be very difficult for them to urinate because it's going to burn because that tissue is torn. So if a catheter gets pulled out, you have to notify the nurse right away. Don't hide it. This is a real problem right now with CNAs. Patients or CNAs or somebody will pull the catheter out and the CNA just won't tell anybody because they're afraid of getting in trouble. Well, what you've done is effectively limited my choices. There's nothing I can do now because it's too late. I can't put a catheter in. There's too much swelling there. Okay, so let the nurse know. And, you know, as far as getting lectured goes, yeah, if you pulled a catheter out, you probably deserve to have a little lecture so that you can remember just how important this is that you're playing around with somebody else's life. You deserve that lecture. Right? Okay. But we do this more than anybody else. Patients that are walking, yeah, we pull catheters out. If you've ever watched any medical shows on TV, this is something I absolutely just roll my eyes at. You'll see CNAs or techs or whoever walking a patient down a hallway, and they've got an IV pole, and they've got the catheter bag hanging on the IV pole. No, catheters go below the hips, not on the round handhold. Definitely not. No. And nobody's correcting them. They're just letting it happen. This guy's getting an infusion of pee. Somebody should call that out. So what do we do if a catheter comes out? Well, we don't want to leave it out in the open, right? If something came out of the body. We got to do something with it, but I don't want you to just throw it away. I do want you to put it in a trash bag, yes, but a clean trash bag. So in the bottom, in a clinical setting, in the bottom of every trash can are clean extra trash bags. So if you just lift the bag up, you can pull a clean bag out, right? And we're going to put the catheter bag and the catheter itself, the whole system, in this clean trash bag. And then we're going to put it in the bathroom and go tell the nurse, hey, room 203, catheter came out while I was ambulating the patient. Totally forgot it was there. I know I deserve the lecture. I'll listen to it in a minute. But the catheter and tubing and bag are in a bag in the patient's bathroom. Now, the reason this is important is because as a nurse, I've got to figure out what kind of problem I'm dealing with. It's a problem, yes, but what kind? If the whole system came out and everything is there, that's a problem I can work with. So if I look and the balloon is still there, it's still inflated, everything is exactly the way it was inside the patient, that's good. But if I look at it and the balloon has popped and pieces of that balloon are missing, where are those pieces? In the patient, that's right. And that's not a problem I can solve. The only way for me to know is to inspect. Okay? So that's why I need you to save it and let the nurse know where you put it so they can inspect it. Good? Now, there's a couple different types of catheters. So this is the one that we're talking about right now. It's called an indwelling catheter or a Foley catheter. And this is the one that has that balloon inflated on the end. But we don't always have to leave a catheter in. Sometimes I'm just putting one in quick to empty the bladder and I'm going to take it. I'm not leaving it. I'm just going to put it in, empty the bladder, take it out. I don't need a balloon on the end of those. So we actually have a special catheter just for that purpose. And it's this one. This is called a straight cath or an intermittent cath. It's not going to have a balloon. So notice it only has one port here, where this one has two, one to fill and empty the balloon and one for the urine. This one just has one. No balloon at all. So this is called a straight cath or an intermittent cath. It's also, because healthcare, called a Red Robinson. Because the guy that invented it, his name was Robinson. And the color is red. Now, the reason we do it red is to make a visual distinction between the two. And then we have a special male-only catheter, and that's this one. This is called a Texas cath or a condom cath. I'll pass this around so you guys can see it. A Texas cath or a condom cath. This goes on just like a condom. Sticky on the inside so it stays in place. And it collects the urine as it comes out of the patient. And it stays in place for up to 3 days. Now, CNAs can put these on. Still has this port here, this port here, and this port here, all the same thing. They all attach to a bag. Same thing. This is better than these as far as infection control risk, right? Because nothing inside the patient, everything's outside the patient. So better for infection control risk. Worse for the skin. Because you remember us talking about pericare, right? Adult urine is acidic. Well, this urine is going to sit right here, right up next to the opening of the penis, which is going to eat that skin. So we're going to remove this every 3 days and do really good pericare. We really want that area clean. And we're probably going to put a little bit of a barrier on the skin to help protect it from that acidic urine.
CNAs can or cannot put the...
Can. Yep. Can. Yep. And again, that's something you'd be trained at your job if it's something that you would have to do. So catheter care. We clean the pericare, but we want to hold that tubing out of the way as we clean because we don't want to pull that tubing. If we pull too hard, the balloon comes out. So we want to hold the tubing out of the way. We're going to wipe down the middle, side, side, skin fold, skin fold. Whatever we wash, we rinse, whatever rinse we dry. Okay. So using all 5 leaves, we're going to clean all of those areas top to bottom. And then we're going to hold that catheter where it exits the body. And we're going to use the leaves method and wipe down the tubing, never going back up, right? Not toward the body. So we're going to wipe the washcloth around and wipe away from the body. And we'll do that 4 times with 4 leaves. Whatever we wash, we rinse. Whatever we rinse, we dry. That's catheter care. That's it. Good? Good. All right, so you know all these principles. Let's go through these skill-specific steps one at a time. So we're going to put a chucks under the patient to protect the bed. We're going to hold the catheter out of the way and clean down the patient's skin, middle, side, skin fold, using leaves method. Whatever we wash, we rinse. Whatever we rinse, we dry. Front to back, just like peri-care. And then we're going to hold the tubing, wipe away from the body. Hello? Okay, thank you. Okay, hold the, wipe away from the body. Whatever we wash, we rinse. Whatever we rinse, we dry. And then we're going to remove that chucks out from under the patient. Okay? We'll inspect the catheter bag to make sure it's not touching the floor. It's not coiled near the floor. It's not on a moving part of the bed. And we'll clean up and do our closing. That's the skill. So all of these steps, up there, all of these steps to check off our checklist. We're going to follow the care plan. We're going to do the opening. We're going to wear gloves because body fluids. We're going to use a barrier on our table. We're going to use a privacy blanket, keep the patient in the middle of the bed, washing rules, basin cleaning, skill steps. But do you remember peri-care? There were a whole lot more black on the screen. For catheter care, there's fewer skill steps that you're being graded on. Most everything that you're being graded on are principles that we already know. Okay. And then we'll do the closing. Question? Okay. All right. So this care plan is only for this patient, not for these guys. They have different care plans. Theirs are probably going to be a little different. Now, before I show you this video, okay, I'm going to roll right into drainage bags. The test has these 2 as separate skills. But in a clinical setting, you're going to do them together. Because when we do catheter care, when we clean the tubing and the skin, we're also going to empty the bag. It's done once a shift. So I'm going to show these to you, one right after the other, because in a clinical setting, they really do go together. But for the test, they will separate them out into 2 separate skills. Okay? Okay. So we'll see this video again in a minute. Let's go to page 164. And this is the overview of drainage bag. So down here at the bottom, you can see somebody with your level of experience will have 9 minutes to do this. It's going to be done on a mannequin, not a live patient. The mannequin will be in bed. Charting is required. So this is one of our documentation skills. And we can be off by plus or minus 50 cc's and still be accurate. If you look at the principles down here, detailed here, we know all of this. There's nothing new to learn here. Nothing new other than our skill-specific steps. Page 165 has our care plan at the top, has our supplies at the bottom, along with step-by-step instructions. And right here in the middle, you can see the documentation sheet that we're going to be using for this. It can also be found on page 169 of your book. So here's our care plan. Empty the resident's urinary drainage bag into a graduate container and measure and record the urinary output in mLs or cc's on the intake and output form. A lot of words. And what it's saying is empty the bag and measure. Okay. In healthcare, do we use ounces or do we use mLs or cc? Yeah, mLs. Yeah. They're going to give you a specific form to use, which we just saw in the middle of that page. It's also on page 169. That's the form they're going to give you to document on. Make sure you document on that form. So I told you a few minutes ago, there's a couple different types of bags. So the ones that we have focused on so far are the larger bags. They're these guys. This is called a bedside bag. It holds quite a bit of urine, 2 liters of urine, 2,000 cc's, 2 liters of urine. But if our patient is out and about in the community, nobody wants to carry a suitcase of urine with you to Walmart. People will stare. It's awkward. It's odd. It's just not cool. So we have a different type of bag that people can wear if they're out in the community. And that's this kind of bag. This is called a leg bag. Works very similar, but it's going to attach using straps to the inside of the thigh or the calf. And it's going to hold urine. It's going to hold less urine than the big bag. It'll have to be emptied a little more often. It's emptied through a twist port down at the bottom. And patients, a lot of times, if they have leg bags, they'll just go to the bathroom, put their foot on the toilet seat, open the twist valve, and direct the urine into the toilet. So it's very convenient for patients that are ambulatory and in the community. You'd be surprised how many people are wandering around with catheters, and you have no idea that this is happening. All right, so if the patient is in bed or in a clinical setting, we generally use the bigger one because we have to be able to see what we're working with. We want to look at the color. We want to look at the amount. It's just kind of everybody's assessing that as they're walking in the room. So in a clinical setting, we tend to use the bedside bags. Both of them are going to attach to the catheter through a port. They attach the same way. They work essentially the same way. They just hold urine. Now, all of them can be emptied using different emptying ports. So this is the one that we're using here and for the test. This is called a T valve. This one is a clamp valve. It literally clamps shut. And then this one we've already talked about is a twist valve. For the test, you will be trained on the valve that you're expected to use at the testing center. They will tell you, here, if you get this skill, this is our drainage bag. We have a T valve. This is how you open it. This is how you close it. And then they will let you do your skill. Okay, good? Okay. So CNAs have to have additional training on how to change the bags. Do not disconnect the bag from the catheter to empty it. We're not going to empty it that way. We're going to empty it through the emptying port. So that's what this is here. This is a T valve. Jake, you'll need to slide in here.
Here we go. Coming to you.
Yep. Okay, do you see how over here you can see the hole, right? When I slide this to the side, that hole slides over, and now I have an open. Oops, let's see here. See how it's now open all the way through? You can see all the way into the bag. If I close it, it's now closed. You guys see that? This is a T valve. When you are done emptying this, it is critical that you close the valve before you put it away. If you leave that valve open, that allows bacteria to get into the bag. It also allows urine to get out, and you'll end up with a huge mess. Okay? So we open it to empty, we close it, and then we put it back in its little house. This is where it lives. When I'm opening and closing this valve, notice that my finger never goes to this end of the catheter or of the bag. This has to stay clean. We don't touch it. It can't touch anything. It can't touch your hand, your gloves, the bed, the cup, the chucks, nothing. It touches nothing. So when you're opening this valve, you have to keep your hands behind the valve. to open it and also to close it. Good? Make sense? Okay. When you're putting it back in its little house, you've got to be super careful not to touch a ton of stuff. It comes right out and it goes right in without touching a lot of stuff. Pass that around for you guys to see. Thank you, Jake. All right, don't let that port touch anything, nothing. So when you're emptying the bag, we're going to put a chucks on the floor. We're going to put the container on the chucks. And with gloves on, we're going to empty the contents of the bag into the container. You can tilt the bag. You can lift the bag, not above the patient's hips, though. Don't let that port touch anything. Now, for the test, let me go back here. For the test, the liquid in the bag will be yellow. It is not urine. It is not Mountain Dew. It is yellow food coloring in water. But they color it on purpose, excuse me, because we have to measure. And if it's clear, it's going to be harder to see, to measure. So they color it on purpose so that when it comes time to measure, we have something of contrast to be able to measure accurately. Now, when we're measuring, it has to be on a barrier, on a flat surface, and at eye level. All three of these are on the same checkpoint line. So if you don't have it on a barrier, you don't get credit. If you don't have it on a flat surface, if you're just holding it, you don't get credit. If you aren't at eye level with it, if you don't get down and read it at eye level, you don't get credit. All three of these are on the same checkpoint. So we have to make sure that we get all of them to get credit. Okay, so we are going to measure to the nearest line. And of course, we're going to use cc's in healthcare, not ounces. So I'm going to measure at the nearest line. So if you see here, this is right at the 450 line. So how much is in this 450? If it was a little bit higher, it would be 475. If it was a little bit lower, it would be 425. We round to the nearest line, whatever line it's nearest. This is, let me pass this around so you guys can take a look at the cup as well. We are going to have to document this. We're going to document on that intake and output form. Is urine intake or output? I hope so. If you document urine on this line, you have stated, remember, this is medical documentation is a legal form. This is like you standing up in a courtroom, hand on the Bible, hand in the air, saying, I certify that this patient drank 450 cc's of urine. Because it's intake. If you document it up here, you are saying this patient took in 450 cc's of urine. Lawyers are not nice people. They're not going to say, oh, I understand you made a mistake. Lawyers are not going to do that. They are going to give you all kinds of grief over the fact that you documented in the wrong space. The test will fail you if you document an intake. This isn't just a little mix-up, a little mistake, a little oopsie. This is a legal form, admissible in a court of law. It has to be accurate. Good. I had a student that came back in tears. She failed because she documented in the wrong space. She's like, I was nervous. I just didn't catch it. I don't understand why I failed. Well, you failed because you falsified a legal document. It's not the fact that you missed a step. It's what effect does that step have on the patient and their well-being. Make sense? So don't make that mistake. All right. So we're going to use these steps. Oh, okay. hold on. So let me go over these drainage bag steps. So we're going to put a barrier and a cup on the floor under the bag. We're going to tilt the bag, open the port, and empty the contents of the bag into the cup without letting that port touch anything. We're going to close it and return it back to its house without touching a whole bunch of stuff. And then we're going to carry that container with the chucks to the bathroom. Do you guys remember how we had to use the chucks around the bedpan? Same reason. Take that chucks, wrap it around the container, take it to the bathroom, and then we're going to put the whole thing on the lid of the toilet. So now it's on a barrier, it's on a flat surface, and I have to get down and read it at eye level. After reading it, I'll dump the urine in the toilet because that's where urine goes. We're going to rinse the basin, dump the rinse water in the toilet because that's where urine went. And then we'll put it away and clean up. We're going to make sure that the bag is above the floor, not coiled near the floor, and hanging on a non-moving part of the bed lower than the hips. We're going to document what we're going to do our closing. Thank you very much, Ms. Jones. Is there anything else I can get for you? Yada, yada, yada. Open curtain, wash hands, document on the output line. Then we're going to wash our hands again. So we'll use these steps to get these checked off. We're going to follow the care plan. We're going to do the opening. We're going to wear gloves. We're going to use a barrier. We're going to clean our basin the way we clean all other basins. We're going to do the skill steps, and there's quite a few on this one, quite a few. And then we'll do the closing. Notice that we don't get as many check marks for the closing on this one. It's more skill steps than it is principle steps. All right, this one's only for this patient, not for anybody else. So we're going to watch 2 videos back to back, catheter care and then drainage bag. And then the rest of the class will be practice because I am done with skills. That's it. All right, Jake. Good afternoon, Mrs. Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I'd like to perform catheter care. Is that okay? Okay, I'm going to close your curtain for privacy, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I can get my clean supplies. We're going to place a barrier on the table with the absorbent side facing up. This gives us a clean area for our clean supplies. And for this skill, we're going to need 1 underpad. We're going to need a towel, 4 washcloths, 1, 2, 3, 4. We're going to need a privacy blanket. We'll bring this over to the patient area. And I'm going to need a basin and soap. And a set of gloves. All right, Ms. Jones, I'm just going to fill your basin. I'll be right back. To fill the basin, I'm going to use a paper towel to turn the faucet on because my hands are clean. I'll use my wrist to feel the water temperature. It should feel warm, not hot, not cold, just warm. And we'll fill the basin about 1/4 of the way full. Mrs. Jones, would you like to check the water temperature? It's good? Wonderful. Okay. I'm going to place this privacy blanket over you, and this is going to help keep you warm and provide privacy as we do this skill. So I'll lay the privacy blanket over the sheet without snapping it or shaking it, and then pull the sheet down to about your waist. I'll put the washcloths in the basin. That way they get warm. And I'm going to prepare the underpad to go under the patient. I'll open it up. I'm going to hold it up lengthwise with the absorbent side facing me, and I'll roll it all the way to the end. Now I can put my gloves on. Okay, Miss Jones, we're going to place an underpad under you to keep your sheets dry while we do this skill. So I'm going to place an underpad on the bed. And in just a moment, I'm going to ask you to scoot toward me. I'm going to roll you on your side, and then we'll spread that underpad out. So on the count of 3, go ahead and scoot toward me. 1, 2, 3. Thank you. And now I'm going to roll you on your side. 1, 2, 3. And as I roll the patient, I want to be careful not to put any stress on this catheter or the tubing. You don't want it pulling tight. So I'm going to unroll the chucks underneath the patient and tuck it under her hip. Miss Jones, come on back and scoot to the middle of the bed, please. Okay, Miss Jones, we're going to repeat the process. Go ahead and scoot toward me. And we're going to roll you onto your left side. 1, 2, 3. And I'll smooth that chucks out underneath the patient. Come on back onto your back. And then scoot to the middle. Now we can begin the cleaning. Miss Jones, I'm going to expose you. I'll make this as brief as possible. But please let me know if you're uncomfortable in any way. I'm going to roll the privacy blanket, making sure that I get the gown inside the blanket as I roll it. But I don't want to grab that catheter as I'm rolling the blanket. So you want to be very gentle with this process. This is going to expose the peri area. And then I'll place a towel over the upper thighs and make sure that the catheter tubing is on the towel. This is to help minimize exposure, increase comfort, and gives a place to put the catheter while we're cleaning it. Now I'm ready to start cleaning. I'm going to take my first washcloth, wring it out, and I'm going to soap 5 corners. 1, 2, 3, 4, 5. I'm going to hold the catheter out of the way, retract her labia, and then wipe down the center, top to bottom, and then move away and fold that leaf. The second leaf will wash the outside of the labia, top to bottom. We'll fold that leaf over. This is going in one direction only, top to bottom. This third leaf is going to wash the other side of the labia, top to bottom. We'll fold that over. The fourth leaf will wash the skin fold between the leg and the groin, top to bottom. We'll fold that over. The last leaf will wash the skin fold on this side, top to bottom. Now we'll set that aside on the barrier. And whatever we wash, we rinse. So we're going to wring that washcloth out really well. Hold it using the leaves method. I'll hold the catheter out of the way and open the labia and rinse down the center one direction, top to bottom. We'll fold that over. We'll rinse the outside of the labia, top to bottom, fold that over. The other outside of the labia, top to bottom, fold that over. This is going to rinse the skin fold. Fold that over, rinse the skin fold. We'll set that aside. Now we're going to clean the tubing. So I'll get washcloth number 3, wring it out really well, hold it using the leaves method. And I'm going to soak 4 leaves. 1, 2, 3, 4. I'm going to hold the catheter where it exits the body so it doesn't pull on the inside. Wrap the washcloth around the catheter and wipe away from the body. We're going to fold that over and repeat 3 times. Hold the catheter, wipe the washcloth around, and move away from the body. 2, 3, changing the leaf for each stroke, and 4. We'll set this aside. Whatever we wash, we rinse. I'm going to wring the rinsing washcloth out thoroughly, hold it in the diamond shape in my hands, hold the catheter where it exits the body, wipe the washcloth around, and rinse going down the catheter. We'll fold that leaf, rinse 2, fold that leaf, rinse 3, fold that leaf, and rinse 4. We'll set that aside. Whatever we rinse, we dry. So we'll dry the peri area top to bottom and the catheter tubing. We can remove the towel, set it on the table, and we're going to unroll the privacy blanket, trying to be careful not to touch that gown with your soiled gloves, and we'll cover the patient up. Mrs. Jones, can I get you to scoot toward me, and I'm going to remove the pad that's under you. Go ahead and scoot toward me, and on the count of 3, you're going to roll up. 1, 2, 3. I will roll the soiled chucks toward the patient and tuck it underneath her hip. Come on back, Miss Jones. When I'm moving Mrs. Jones, because my gloves are soiled, I'm only touching the outside of the privacy blanket. Mrs. Jones, scoot to the middle of the bed, please. And now we can remove your chucks. If you can scoot toward me, again, my soiled gloves are only going to touch the outside of the blanket. And then you're going to roll up on your side, 1, 2, 3. And I'll remove that chucks from under the patient. Come on back onto your back. And then if you can scoot to the middle. Thank you. I'm going to go dispose of this. Okay, Mrs. Jones, you're covered. You're safely in the middle of the bed. I'm going to go dispose of your linens and clean your basin. I'll be right back. These items will go in dirty linen. We're going to clean this basin the way we clean all basins. I'll bring the basin to the sink and we'll dispose of the water in the sink. Rinse the basin and then dispose of the rinsed water into the sink as well. I'm going to set that down, disinfect it per facility policy, and then pick it up with a paper towel. I'm going to get a clean paper towel to dry the inside. I'm going to get a clean paper towel to dry the outside. And then one more for the drawer. On the way, we'll pick up the soap, place it in the basin, use the paper towel to open the middle drawer, pick up the lotion and put it in the basin, and then store the basin in the drawer. We'll close it with a paper towel and then throw those paper towels away. Now we can dispose of the barrier. This will go in the garbage. And I can remove my gloves. Okay, Miss Jones, I'm going to remove your privacy blanket now. I want to check your tubing real quick just to make sure that it's not kinked and you're not lying on it. So it looks good. It's not near the floor. So I'll pull the sheet up over the privacy blanket. This ensures that you're always covered. And I'll remove the blanket as I do so. Want to make sure that the blanket is rolled into a ball so trailing edges don't contaminate other surfaces. We'll make sure that the sheet looks good. All right, Miss Jones, just let me go dispose of this in dirty linen. I'll be right back. We'll adjust the sheet on this side. There you go. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine? Your bed is in the low position. Your environment is clean. Here's your call light. If you need anything at all, go ahead and press the red button. We'll be happy to come help. I'm going to open your curtain and return your overbed table to storage. Now I'll go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Good evening, Mrs. Jones. How are you today? Fantastic. I need to empty your urinary drainage bag. Is that okay? I'm going to close your curtain for privacy, wash my hands, get my supplies, and I'll be right back. After washing my hands, I'll get my supplies. We're going to start with the chucks. This is going to go on the floor under the bag. We're going to place the barrier on the floor directly under the urinary drainage bag. So we'll unfold it and we'll place it under the bag with the absorbent side facing up. I'm going to go get a set of gloves. And we're going to get the graduate container out of the drawer. You need to make sure that you put your gloves on before you get the graduate container. We're going to place the container on the barrier directly underneath the bag. We use the emptying port to empty the bag. This is a T-valve. We slide it to the side to open the valve, and then we're going to empty the urine into the graduate container without letting that port touch anything. Once the bag is empty, we'll close the port and place it back in its little house. All right, Ms. Jones, I just want to check to make sure the tubing is coiled on the bed and you're not lying on it, and that it's not coiled near the floor either, where it could become a tripping hazard. Now, I can wrap the chucks around my graduate container for safe and secure transport to the bathroom. We're going to set it down on the lid of the bedside commode and unwrap it, turning the cup around so that we can read the amount of urine that's in the cup. We need to be at eye level. It needs to be on a flat surface and on a barrier. I'm going to throw the chucks away. open the lid and the seat and dispose of the urine into the bedside commode. I'll rinse the cup and dispose of the rinse water into the bedside commode as well. We'll close that, set the graduate container down in the sink, and disinfect it per facility policy. I'll pick it up with a paper towel, dry the inside with a paper towel, throw that away, dry the outside with a paper towel, throw that away, and one more for the drawer. Okay, Miss Jones, I'm just going to return this to storage using a paper towel to open the drawer. And closing the drawer, we'll throw those paper towels away, and then I can remove my gloves. You take a peek at your tubing just one last time. Everything looks good. Are you comfortable, Mrs. Jones? Is there anything else I can get for you while I'm here? No? Would you like a magazine before I go? Your bed is in a low position. Your environment is clean. I'm going to open the curtain. Here's your call light. If you need anything at all, just press that red button. We'll be happy to come back and assist you. Thank you very much. I'm going to go wash my hands. After washing my hands, we'll document the amount of output on the documentation sheet provided by the evaluator. We're going to document the time of output, the type of output, which is urine, the amount of output in cc's, and my initials. And we want to make sure that we're documenting in the output section. After documenting, I'll wash my hands one final time. After washing my hands a final time, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done. All right, any questions on that?
For the timestamp that you put on there, it looks like it was military.
Yep, I was just going to address that. If you use regular time, and you can for the test, you must write AM or PM. Don't assume. Military time is best. You may have a written test question on military time. I do have in your skills book a whole lesson on military time. It's on page 49 if you want to use that to learn military time. But you can use regular time on the state exam. Just make sure that you indicate AM or PM. Okay. All right. Remember that the practice kit has the drainage bag and the graduate container, which can help you with this particular skill. Homework tonight, last chapter, chapter 10. Chapter 10 is on employability, stress management, that type of thing. It's a short chapter, an easy chapter, not hard at all. You'll get a wrap-up email today. Remember, on Wednesday, you have to return the yellow book. So please bring that to class with you on Wednesday. We will take a class photo on Wednesday as well. I'll put it up on my Facebook page. You can go grab it and do whatever you want with it. Jake, you want to pass out the review sheets, please? Yeah, and for those of you that are attending virtually, we have the new practice test up online on shop.4YourCNA.com. Go check it out. We are charging for it, but I do have a discount code for you. If you email me for the discount code or email me at 4YourCNA@gmail.com. I'll give you a secret discount code to help you with that. You guys are all, my classroom is all getting it for free.
And you should have had it in your email inbox already. I sent that out earlier today.
Yep, so it should be there waiting for you. All right, so that is it for today. I will see, sorry, I was trying really hard, but I will see you guys on Wednesday for the last class.